All
Good morning, we're live.
right. Well, welcome everyone. Good afternoon. We're about to begin what is really a key activity of the Health Policy Commission, which we do every year in conjunction with members of the healthcare financing committees in both the Senate and the House. And I'd like to welcome Chair Friedman and Chair Lown, who will be joining us and speaking in a minute. Just to remind everyone, what we're about today is a discussion of the underlying growth in spending that occurred in 2 years ago, year and a half, depending. And we use that information plus other information, more recent information, to determine what the benchmark will be for 2023. Our esteemed Executive Director, David Sells, will explain this in much more detail. As I said, this meeting is in conjunction with the two legislative committees because our relationship is with them. David will explain what we have to decide in our next meeting in terms of the benchmark. And what we have seen over the last 12 years since the formation of the Health Policy Commission in 2012, so 10 years, is that the benchmark plays a very important role in determining how prices and expenditures go up in the state and to what extent they are going up faster or at the same level as the benchmark. In making these decisions, we are so fortunate here in Massachusetts to have what, in my view, is the finest data collection system in the country. And the group that is responsible for collecting the information and analyzing, the Center for Health Information Analysis, will make a presentation this afternoon about their findings during the early stages of the COVID virus pandemic. So we look forward to that. In addition, we will get more updated information from our own David Auerbach, who is the director of our our research group, and from a really outside, really knowledgeable person, Dr. Aditi, who will give us a broader view of the importance of price increases on total expenditures. Today's meeting is more of listening not only about the facts, but we will also receive testimony from a number of groups who are very much impacted about the benchmark. Ultimately, we will have to decide in our next meeting what that increase should be. Before I go any further, I would like to turn the program over to Chairperson Friedman, both to introduce herself, and all of us know her, but also other members of the Senate that are participating today. So Chair Friedman, welcome.
Thank you so much, Dr. Altman. It's great to be here and to do this this annual event. I am Senator Cindy Friedman, and as co-chair of the Joint Committee on Healthcare Financing. I want to thank you and extend my welcome to you, to David Seltz and the board and staff of the Health Policy Commission, to Ray Campbell and the Center for Health Information and Analysis. And I want to echo Dr. Altman's comments. I actually firmly believe that we have, if not one of the most extraordinary and outstanding data collection groups. And not only are they amazingly intelligent and smart and quick on the turnaround, but they're also incredibly patient in answering all the myriad silly and more complicated questions that we throw their way. So hello to Ray and your group. And I want to extend a special welcome to Dr. Aditi Sen of the Healthcare Cost Institute, and to my colleagues on the House and Senate on the Joint Committee for Healthcare Financing. This is an important topic that touches everyone. This is a growth benchmark that's statewide, and it's a target that we established in 2012. And we know that this is an annual event. And I guess I'm really looking forward to this particular presentation. And I'm also especially looking forward to trying to understand how much of this we can take away in terms of any kind of trajectory or any kind of, are we seeing some kind of true progression in costs, or is this actually a one-time blip that's reflecting an amazing last 2 years in which our healthcare system was, to say significantly impacted would be an understatement, but I'm looking forward to understanding like what is giving us showing us a pathway, and what is just something that is a blip. And it's amazing to see what happens when a pandemic comes your way, but isn't really reflective of what we're seeing as true cost trends. So thank you so much for having us. And I'd also like to welcome, I think I've seen Senator Sear on the call, who's a Senate member of the Joint Committee on Healthcare Financing. And back to you, Dr. Altman.
Thank you so much. And it's always a pleasure to have you join us. So Chair Lown, I wonder if you'd like to say a few words and introduce any members of your group that are joining us.
First of all, thank you, Senator Friedman, and you've been a great partner and co-chair of the Healthcare Finance Committee, and I appreciate all of your work over the last year and a half. Thank you, Dr. Altman, to David Seltz, Colleen, and the entire staff at the Health Policy Commission. Thank you, Ray Campbell and his staff at CHIA, for all of your work over the last year and for hosting this hearing today. I would also like to thank Speaker Mariano and my colleagues in the House of Representatives who are here today. We have I have my Vice Chair, Representative Jay Livingstone, Representative Matt Muratori, and Representative Barbara, and I know we'll have some more joining in. And I know some of my colleagues here in the House will have other meetings today, and they'll be signing in momentarily. Today, we're here for a very important meeting, and there's great uncertainty today in healthcare, both locally and nationally. But here in Massachusetts, our efforts to address cost, quality, and access to healthcare continue in spite of the disruptions and challenges we now face as we emerge from a generational health crisis. For all of that, our focus over the last 2 years has been on pandemic response and addressing immediate and emergency needs. Today at this annual cost growth benchmark hearing, we remember that Massachusetts healthcare system continues to face the same central policy challenge: how to improve population health while keeping costs at controlled and affordable levels. Restraining cost growth has been the driving motivation behind over more than a decade, as Dr. Altman said, since 2012, of policy reforms in Massachusetts. And although the pandemic revealed foundational weaknesses across the healthcare system, it also presented a unique moment for the Massachusetts healthcare community to reaffirm its commitment to create a more affordable, accountable, effective, and equitable healthcare system to benefit all of our residents. We all know that there is no silver bullet for healthcare, but in this rapidly evolving healthcare environment, we have to continue moving forward together because that is who we are and that is our story. The story of health reform in Massachusetts has been one of partnerships, of collaborations. I may even use the phrase shared responsibility once or twice. The ethos of shared responsibility has anchored us to our long-held health reform goals. Provide equitable access to health, high-quality, affordable care, maintain near universal access to insurance, foster a competitive, value-based market, promote efficient, high-quality healthcare delivery, advance fair, sustainable payments for providers, secure the future of community-based providers in our safety net hospitals, advance transparency and data availability, and reduce increases to overall healthcare costs for family and businesses. We must remain committed to this effort, pursuing integrated care, innovating with value-based coverage, expanding prevention and community-based care, while also tackling costs. We need to continually push the system forward for greater efficiency and effectiveness. There is so much work to do, and deciding where to set the benchmark for the next calendar year is just one piece of the puzzle. So on behalf of my colleagues on the Joint Committee of Healthcare Financing, thank you for the opportunity to address you all, and I look forward to working collaboratively with all of you. Thank you.
Thank you so much, Chair Lown. I'd now like to turn the program over to our Executive Director, David Sells, who will go into more detail about what we hope to accomplish today and how important what we're doing is for the whole Commonwealth. David?
Great. Thank you, Mr. Chairman. Good afternoon, everyone, and a warm welcome to you and other members of the HPC board. We also have the full HPC board here with us today, in addition to Chair Lawn and Chair Friedman, members of the Joint Committee on Healthcare Financing, and of course, the public viewing this important hearing today. Thank you for your continued engagement in the work of the HPC and our shared goal of advancing better health and better care at a lower cost for all the people of the Commonwealth. We are so honored to co-host this hearing with the Joint Committee. This is our sixth hearing, number 6, if you can believe it, holding this important hearing. And I also want to extend an additional thank you to the committee staff of Healthcare Financing for working with us to help organize this important event. We have an incredibly rich agenda today. But I really want to encourage all members of the committee and the HPC board to take advantage of some of the experts that we've brought here today, ask questions, provide comments, and we will do our best to answer those questions here, but also remain a resource to you after this meeting to answer any questions that you may have as we wrestle with as both chairs say, incredibly important, but incredibly complicated topics in healthcare. I would also note the full presentation that we're going to present today and the full video of this hearing will continue to be available on our website and on the HPC's YouTube page. I also want to acknowledge that we are conducting this hearing in the context of a still lingering global pandemic. And despite the very positive news in Massachusetts with regard to case counts and positive test rate and primary COVID hospitalizations, which is now below 100, we recognize that the long-term impacts of the past 2 years will continue. I'd like to echo the thoughts of others by thanking and acknowledging the leaders and frontline workers of our healthcare system, which have sacrificed tremendously to provide care and comfort to Massachusetts residents over the last 2 years. We at the HPC and CHIA continue to be really actively engaged in understanding what are the impacts of this pandemic, both on our healthcare system, on our healthcare workforce, on our patients and our and on our overall healthcare system. And we really look forward to working with the legislature in charting a path forward and to take advantage, as Chair Long said, of this unique moment and unique opportunity to chart a path for a more affordable and transparent and equitable healthcare system in the future. For my presentation, I'd like to just provide a brief history and overview of the benchmark, the process by which it is set and modified, and the mechanisms for accountability through our performance improvement plan process. So if we move to the next slide, Massachusetts is rightly proud of its high quality, innovative healthcare system and its long history of policy leadership, including pioneering healthcare reform coverage in 2006, which became a model for the country. This policy leadership was renewed again nearly 10 years ago by the legislature on behalf of the Massachusetts residents and businesses that bear the high and rapidly growing costs of healthcare in Massachusetts. They acted at that time to establish a more sustainable and more affordable trajectory for healthcare costs through the passage of, again, landmark legislation, Chapter 224. Through the passage of Chapter 224, Massachusetts has again become a national leader. And at the center of this legislative effort was the establishment of the country's first healthcare cost growth benchmark and the Health Policy Commission and the Center for Health Information Analysis to help guide the state's efforts. The goal was and is not just containing costs, but really about promoting better quality and better care and better health for all residents. On the next slide, just to speak a little bit more about the healthcare cost growth benchmark. Healthcare cost growth benchmark is a prospective target for controlling the growth of total healthcare expenditures across all payers and is tied to the state's long-term economic growth rate. This idea of tying healthcare costs to the long-term economic growth rate is central to Chapter 224 and reflects the fact that we believe that healthcare and our healthcare industry should grow. This is not a reduction in the amount of revenues that go into our healthcare system. It is really about bending that growth curve to be something that is more sustainable and more in line with other indicators of economic growth, so that our Massachusetts families and businesses do not see this crowding out effect of more and more of their paychecks or their revenue going to healthcare at the expense of all other priorities. I want to emphasize the healthcare cost growth benchmark is not a hard cap on spending, nor on provider-specific prices. It is a collaborative, measurable goal for moderating excessive healthcare spending growth and advancing healthcare affordability. As was said, at the heart of this effort is one of collaboration, partnership, and shared responsibility between government and the private healthcare sector to work together, not just for the business interests, but for the public good. This target, this goal, really only has one enforceable accountability mechanism through the performance improvement plan process, by which the HPC can identify individual health plans or providers that have excessive healthcare spending growth and to whom an improvement plan is warranted. And I'll speak a little bit more about that process. But it is a process that is comprehensive, a multi-factor review that really takes into account the entity's performance over time and the context of that entity's performance, including such factors as that provider or health plan's market size and factors outside of the control of that entity. So this is a very rigorous review process to ensure that when the HPC requires a performance improvement plan, it is only in those cases where it is most warranted and needed. And finally, on the right-hand side of the slide, just a note that what is calculated as part of total healthcare expenditures includes all categories public payers, private commercial payers, Medicare, as well as importantly, the amounts that patients pay in out-of-pocket spending and deductibles. On the next slide, you can see that the law prescribed 3 phases for how this benchmark would be set as tied to that economic growth rate. And I should have mentioned that this economic growth rate is one that is calculated annually between the legislature and the administration through the consensus tax revenue process. So this is a process where the legislature and the administration come together to update what is our long-term economic growth rate, otherwise known as potential gross state product, otherwise known as PGSP. This year, and as has been the case for the last 9 years, the legislature and the administration determined that that long-term economic growth rate is 3.6% annual growth. So there have been 3 phases in the statute that lay out how the benchmark relates to this economic growth rate. In the first 5 years, the benchmark was established exactly at that economic growth rate of 3.6%. In the next 5 years, the benchmark was set at a default rate equal to that economic growth rate minus 0.5 percentage point, or 3.1%. The Health Policy Commission board had limited authority to modify that number upwards to any number between 3.1 and 3.6, subject to legislative review. The HPC board did not elect in any of those 5 years to modify the benchmark from what was set forth in the statute. And finally, we are entering now this 3rd phase as laid out in the law, which returns the benchmark to be tied to that long-term economic growth rate of 3.6% as the default rate. However, the HPC board does have authority to modify that rate to any number either below or above that 3.6% rate, subject to legislative review, which I'll speak about in a moment. On this next slide, I just want to highlight that this is a process by which we are setting a prospective goal. And the reason that this was really wanting to be a prospective goal is because it was intended that we would signal to the healthcare market what they should be working towards. So we want to set that goal in advance so that the industry and market participants can understand where they should be tracking towards and taking actions to try to meet. However, we measure our performance against the benchmark retrospectively. And due to data lags, that can actually take some time. So you will see that here today. Today, we will be discussing our performance for 2020 benchmark, which was originally set in 2019. And you can see that benchmark was set at 3.1%. And as CHIA will talk about later, our performance against that benchmark was actually minus 2.4% due to impacts of the pandemic. The question of where we should set the benchmark for the future, however, is for the next calendar year. So you can see if you move across this timeline, what we are considering as an HPC board is where to set that benchmark for actually calendar year 2023, so next calendar year. So this does create a challenge where we are looking retrospectively at data, but also trying to set goals for the future. And so we hope today to be able to fill in some of these gaps with some of the data that we do know about what has happened perhaps in 2021 to help give us some indication of what has happened over these few years. I would also note that the benchmark is intended as a goal. It is not a projection. It is not what we think necessarily is going to happen if everything happened, if status quo continued. It is really intended to be a goal for improvement. And we have in some years met that goal, and in other years we haven't. But really this is a long-term effort to bend that healthcare cost curve. And in the 10 years since this benchmark was established, we have been below the national, the US growth rate for total healthcare spending every single year, even though we may not have hit our own goals every single year. On the next slide, you can see a little bit about just the process that's laid out in the statute. about how the modification happened. So the first step is what we're here today for. The HPC's board will hold a public hearing in conjunction with the Joint Committee on Healthcare Financing, and really to solicit information from the public and from stakeholders to help inform the HPC board's decision. If the HPC board this year votes to maintain the benchmark at the default rate of 3.6%, the annual process is complete. If the HPC board votes to modify the benchmark to any other number, the HPC must submit that intent to the Joint Committee for further legislative review. The second part of the slide walks through what that potential legislative review process may look like, and an opportunity for the general court to also weigh whether the HPC's decision was warranted. And absent action by the general court, the HPC's board's decision will become the benchmark for calendar year 2023. On the next slide, you can see that same process laid out just in terms of a timeline. So March 16th, we're here today for the benchmark hearing, and the board will be back on April 13th for that decision to meet our statutory deadline of April 15th to set the benchmark. Pivoting briefly, I did want to spend a few minutes just talking about the performance improvement plan process, as this is one of the key accountability mechanisms for the healthcare cost growth benchmark. So this is a very rigorous process. It begins in step one with the setting of the benchmark. Our colleagues at CHIA will then use data collected from the health plans to determine whether there are individual health plans or providers whose health status adjusted total medical expenses for their members exceeded certain thresholds. Those entities are then referred by CHIA confidentially to the Health Policy Commission for further review. At this stage, this is a confidential process, and the Health Policy Commission participates in an extremely rigorous and comprehensive review of all of the entities named to try to understand, both from their perspective, what is driving their healthcare costs and whether a performance improvement plan is warranted and likely to be successful. That process then leads to a decision by the board to require a performance improvement plan and the further implementation of that performance improvement plan. I want to emphasize on the next slide that this is a process that really tries to understand the context of the entity's excessive cost growth, and that this process has not been used as a clear line punishment or on any healthcare entity just because their healthcare costs happen to exceed the benchmark in one given year. In fact, our regulations require the HPC to look at a number of factors to try to understand whether a performance improvement plan is warranted. Factors like the pricing of that entity, the relative price of that entity compared to other market participants, the populations that market participant provides care for, including its share of public payer patients and Medicaid patients, and the services it provides, like behavioral healthcare services. We have to look at their financial condition. And we also are required by regulatory factors to look at factors that lead to increased costs that are outside of that entity's control. And in the case of this rigorous review, if we identify significant concerns about the entity's costs, the HPC board can determine that a performance improvement plan is required and would lead to meaningful cost savings reforms. And of course, as we think about the context of the pandemic and how the HPC will think about enforcing the benchmark, these regulatory factors become very important, and we will be very cognizant of some of these factors, such as factors leading to increased costs that are outside of the entity's control. On the next slide, want to highlight that the benchmark has now become a model for the country, and there are now 5 other states that have established similar targets or healthcare goals that in many ways copy or are inspired by, I should say, what we have done here in Massachusetts. Many of those states have different numerical goals for their targets. I would say that of those that have set goals, they tend to range in the 2.9%, so slightly lower than where we have been, to 3.4%, but really right in the same ballpark of where we have been for the last 5 years of 3.1%. And I would note of interest that just yesterday, Governor Gavin Newsom in California filed his annual budget, which included a proposal for an establishment of an Office of Healthcare Affordability to help guide that state's efforts to reduce the cost of the growth of healthcare costs. Finally, on the next slide, how the HPC works with our market participants to help influence and achieve this goal is through a number of different policy levers. We do research and reporting, which we'll demonstrate for you today. We also partner with entities. We make investments and grants and work together with healthcare providers to test and innovate new ways of delivering care that truly deliver on that promise of the triple aim. We work as a convener to bring like-minded individuals together to help solve some of these big challenges. And we also act as a watchdog on behalf of the public that ultimately bears the high cost of our healthcare system. So with that, before I turn it over to our colleagues from the Center for Health Information Analysis, I'm going to pause and just open it up for questions about the history and the process for modification, as it is somewhat complicated.
Thank you, David. Senator Friedman or Representative Lown, are there any questions that you or your members have about this process that we can be helpful with?
I don't currently see any. Very well laid out, so thank you, David. But don't see any questions from my colleagues at this point.
Okay. Well, as we get into the detail of what's been going on, feel free to join, either ask, have your members either raise their hand or just jump in if you want. But we're now going to turn it over to our annual report from our colleagues at CHIA.
All right. Thank you very much, Chair Altman, Executive Director Seltz, members of the Health Policy Commission, Chair Friedman, Chair Lawn, and members of the Healthcare Financing Committee. My name is Ray Campbell, and I'm the Executive Director of the Center for Health Information and Analysis, also known as CHIA. I'm pleased to be here to present findings from CHIA's annual report on the performance of the Massachusetts healthcare system for the year 2020. Massachusetts places a higher priority on measuring its healthcare system than any other state in the country. In light of the events of the past 2 years, having good data on our healthcare system has never been more important than it is right now. As you all know, COVID-19 had a significant impact on healthcare utilization, service delivery methods, and payer and provider finances starting in 2020. To do a better job of capturing these impacts, CHIA has added new chapters to this year's annual report, including more information on provider and health system financial and utilization trends. Where possible, we've extended some of these trend lines to look at developments beyond the end of 2020 to provide additional context. In so many ways, 2020 was an unprecedented year for the Massachusetts healthcare system. In considering the data and analyses contained in CHIA's 2020 annual report, please keep the following in mind. First, most of the findings in this report focus solely on calendar year 2020 and should be viewed within the context of the extraordinary time-limited events that were happening during that year. Second, CHIA and other state agencies have more current data assets that are available to policymakers as they consider the numbers in this report. For example, CHIA has patient-level hospital discharge data and emergency department data through the end of 2021, and we will soon have hospital financial data for all of 2021 as well. Third, federal COVID relief funds were excluded from CHIA's THCE calculation, as these funds were distributed on a fiscal rather than calendar year basis, which is how performance against the benchmark is assessed. And many of these funds bypass the insurer-provider relationship that THCE measures. However, just to be clear, CHIA did capture all of the state and federal relief funds that were distributed to hospitals and nursing homes, and these are shown in new chapters of the annual report. Lastly, due to actuarial cycles, premiums in effect in 2020 were developed prior to the pandemic using historical spending data. But as we now know, actual utilization was far lower than projected. However, there are various mechanisms in place, including medical loss ratio requirements that prevent health plan administrative costs from rising above permitted levels. Those are my introductory remarks. Thank you for your attention. I'll now turn it over to Lauren Coakley-Sears to start walking through the major findings. Lauren?
Great. Thank you, Ray. Good afternoon, everyone, and thanks for that introduction and highlighting of the background and major components of the report. So I'm going to start off by walking through key findings from the total healthcare expenditures, hospital utilization and finances, and total medical expenses chapters. And apologies in advance, as the first section of the presentation contains many granular data points, but I think these are all important to broadly demonstrate what happened to healthcare spending in the Commonwealth in calendar year 2020. So in 2020, THCE totaled $62.6 billion, equating to $8,912 per capita, a 2.4% decrease from 2019. This was the first year since reporting on the benchmark that we saw a negative trend in per capita spending. The decrease was driven by commercial spending, which decreased 4.5%, correlating with a 2.1% decrease in enrollment, and Medicare spending, which decreased 3.4%, despite a slight increase in enrollment of 1.1%. Even with the overall negative trend, we saw modest increases in spending for mass health and other public programs, which includes the VA and the health safety net. The most sizable growth was in the net cost of private health insurance, which increased 31.2% in 2020 and captures the cost to plans for providing healthcare in Massachusetts. So if we go to the next slide, before breaking out the THCE spending by service category, we wanted to provide some context around the 3.2% mass health increase in spending at the program level. So correlating with spending growth, mass health experienced a 4.5% increase in enrollment due to federal mandates for continuous coverage, with enrollment increasing for all programs apart from PCC. Looking at spending trends by mass health program type, supplemental payments increased 43% in 2020, which included an additional $495 million in supplemental COVID funding to facilities. Spending also increased for programs for the dually eligible by 6.8%, ACOBs by 5.4%, and MCO and ACOAs by 1.1%. And moving into a look at THCE by service category at the market level, on the next slide, we saw a reversal in many of the trends that we've seen in previous reports, as expected, due to disruptions to the healthcare system in 2020, primarily decreased utilization, as well as the temporary suspension of elective procedures due to COVID-19. Hospital outpatient, a previous driver of THCE, decreased 11.1% in 2020. Physician spending decreased 12%, and inpatient spending decreased 1.8%. I'll note here that if federal relief funds were included in THCE and allocated to calendar year 2020, combined inpatient and outpatient hospital spending would have increased by 1.9%, and physician spending would have decreased at a slightly lower rate of 10.2%. Despite decreases in several major service categories, we did see increased spending for both pharmacy and non-claims in 2020. Gross of rebates, pharmacy spending increased 8.2%. And some of the reasons we suspect this trend continued to increase were the use of 90-day supplies for drugs rather than the traditional 30, the increased use of telehealth for prescribing, and as national data suggests, higher drug prices. Non-claim spending increased 28.8% in 2020, driven largely by new supplemental payments for COVID relief, as well as changes in risk settlement contracts with providers. And this next slide looks at the same data, but net of prescription drug rebates. This is inclusive of both rebates for both private and public payers. In 2020, we saw a narrowing in the gap between gross and net pharmacy trends due to slowed overall rebate growth. Overall rebates increased 9.9% in 2020, slower than the 23.8% increase we saw in 2019. This resulted in higher net pharmacy growth in 2020 of 7.7%, converging with the gross trend of 8.2%. And after talking with several data submitters, we believe some of the reasons for these trends were several policy changes in the negotiation of drug prices between payers, PBMs, and manufacturers, particularly on the public payer side. So moving away from THCE and looking a little bit more into utilization on the next slide, I think this helps to contextualize some of the downward trends in hospital spending that I spoke about in THCE. The data displayed here is more current than the THCE data, as you'll see, and shows adult non-obstetric hospital inpatient discharges from 2018 to 2021. You'll see a large drop in discharges in the spring of 2020, as well as in the winter of 2021, correlating with peak COVID periods. In the next slide, we're looking at hospital financials, and this chart shows the impact of federal and state COVID relief funds on hospital operating revenue and expenses. So as a note here, this data is reported on a hospital fiscal year basis rather than calendar year, and these are aggregate results. So individual hospitals may have had different experiences than what these numbers demonstrate. The dark blue bars here represent net patient service revenue, which are the revenues collected for patient care. And these declined from $28.3 billion in 2019 to $26.5 billion in 2020. However, after adding in the relief funds of just over $2 billion in 2020, the operating revenue was bolstered to keep pace with the previous period, slightly exceeding the total reported expenses, which is the light gray bar to the right. And for my last few slides, I would like to shift to looking at TME spending, which David discussed a little bit earlier. So TME spending, we report on both an unadjusted and an adjusted basis. So for these charts, as a note for the commercial population, this data only includes the reported full claim data for payers without additional adjustments. And for information on the Medicaid payers, as well as the managing physician group trends, you can refer to our larger report. But on an unadjusted level in 2020, all commercial payers reported PMPM spending growth below the healthcare cost growth benchmark, with all but one payer reporting a negative trend. However, if we go to the next slide, if we look at this data on a health status adjusted basis, you'll see much more variation across payers, with several reporting positive trends. This variation is due to differences in the aggregate risk scores in these payer populations. In 2020, we saw overall lower risk scores reported by most payers, which were due to fewer inputs, a result of decreased utilization, into risk adjustment models. While, as we've discussed, 2020 was an extraordinary year, CHIA will continue to monitor risk score trends in the future and conduct further analyses. I'm now going to turn it over to Ashley Storms, who will discuss the patient and member experience chapters of the report.
Thanks, Lauren. So new in this year's report, we're including a selection of HEDIS scores for the commercially insured population. Each of these measures was collected for 2018, which are the white circles, and 2020, which are the blue circles. And higher scores on these measures indicate better clinical quality performance. So far, you've heard us talk about decreasing utilization due to the pandemic. And along these lines, we observed lower scores in 2020 for quality measures requiring an in-person test or visit, including screenings for cancer and other conditions, which you'll see in the lower section of the slide. However, we also saw quality scores improve for behavioral health follow-up care and medication management measures, which may reflect the expanded access to telehealth during this time, as these services were those that could be provided remotely. And this slide is only presenting a subset of the data that we have on quality measures, but CHIA will be publishing a full quality report later this year, so please stay on the lookout for that. Turning to member cost sharing. Historically, we focused on affordability in this report, and specifically the metric of member cost sharing, which includes copays, coinsurance, and deductibles. Once again, 2020 was certainly an outlier year, and we saw member cost sharing fall 17.2% to $49 per member per month. This was primarily driven by the decreased utilization and reflects an overall drop in medical spending. However, there were also policies implemented in 2020 that eliminated cost sharing for particular services. This included a division of insurance policy requiring payers to waive cost sharing for most COVID-related testing and treatment services. We also saw payers voluntarily waiving copays for some other services, including telehealth visits or behavioral health visits. One other thing I'll point out while we're still on this slide is that we continue to see variation by market sector or employer size, with members covered by larger employers having lower average cost sharing. And that's directly related to something that you'll see on the following slide, which is differences in high deductible health plan adoption across different market sectors. So if we could go to the next slide. Yes, perfect. So by 2020, we see that over 38% of commercial members were enrolled in a high deductible health plan, defined here as an individual policy of at least $1,400 in 2020. And this included 4 out of 5 unsubsidized individuals, and more than 60% of members enrolled through employers in the small and mid-sized group sectors. So more than 60% of members covered by an employer with 100 employees or fewer. And so what I'd like to communicate today is that the potential is still very much there for commercial members to be faced with affordability concerns as utilization returns to normal levels. Another important metric that poses costs for both members and employers is premium growth. For fully insured plans, the average premium amount was $529 per member per month in 2020. This represented a 2.6% increase from 2019, similar to the prior year's growth. Something to keep in mind when we're looking at premiums is that those in effect in 2020 were developed prior to the pandemic, as Ray said, using historical spending data, which is why we see a disconnect between the premium growth and what actually occurred in terms of healthcare spending. The data that I'm presenting here already reflects premium refunds and credits that some payers were issuing in 2020, as it became clear partway through the year that utilization would be much lower than expected. And it also reflects MLR rebates that were issued for 2020. Now on the next slide, we're going to take a look at how those premium funds were spent. The pie chart on the left represents all premium revenue, with the large light gray portion illustrating medical claims costs, and the dark blue red representing the funds that remained after payers had covered those medical costs. This has sometimes been referred to as premium retention, but for today, we're going to call it non-medical spending and surplus so that we can highlight the various ways in which that money was used. And overall, this bucket of non-medical spending and surplus grew over 35% in 2020 to $85 per member per month. Now, the stacked bars at the right illustrate what the money was spent on and how that has changed over time. And you'll see that costs for general administration, commissions, and healthcare quality improvement expenses were relatively stable from 2019 to 2020. The components where we saw the most growth were in taxes and fees, which grew from $5 to $12 per member per month, and in net gains or surplus, that darker blue segment on the left, which grew from $4 to $19 per member per month between 2019 and 2020. And this surplus represents whatever money is left over once medical and non-medical expenses have been paid. And we know that now that the 2020 growth was driven by lower than expected spending on healthcare services. Historically, this surplus category is also where we've seen the most variation from one year to the next, given the inherent uncertainties of the actuarial underwriting cycle. One thing I would also like to note here is that we do have medical loss ratio requirements to serve as guardrails to keep health plan administrative costs in check. And for the 2020 year, there were increases in both the number of Massachusetts members qualifying for MLR rebates and in the average rebate amount paid out. And because the federal MLR formula considers a rolling 3-year period in determining rebates, the plan's experiences in 2020 will continue to impact the rebates paid out over the next 2 years as well. So thank you so much. If we go on to the next slide, I know that we've hit a lot of highlights here of a 130-page report. So I do encourage you to take a look at that as time allows. And I think, as Ray said, we also know that the story does not stop with 2020. In fact, you'll hear right after this presentation what continued to happen in 2021. We do have more recent metrics going into late 2021 on our website as well. So I've included links for those here. Thank you so much for your time.
Are there any questions of anyone so far? I want to thank Ray and the team so far. Detailed stuff, but presented beautifully.
Thank you.
Okay. So now we're going to turn to our own internal analysis and our Director for Research, David Auerbach.
Okay. Thank you, Stuart. And good afternoon, everyone. I'll be presenting some material in four sections, starting with some additional context and reflections on the 2020 trends that CHIA showed us, a discussion of affordability of care, and then some data helping us look ahead a little bit into what we know for 2021, both nationally and within Massachusetts, so we can help think about what Senator Friedman mentioned as, was 2020 a blip, and what do we think is happening in the future, and where is this going? Okay, next slide. So here we're showing the long run performance against the benchmark for the entire time that HPC has been in existence. And as we know, you see there the minus 2.4% from 2019 to 2020. So as David said, we've been above some years, we've been below some years. And I'll note that the long run, the average over all these years together is about 2.8% growth per year. And if you don't count 2020, it's about 3.56% growth per year. Next slide. So getting back into 2020, and we did show this before, this is data reported by the payers as part of their pre-file testimony. And a key point about what happened in 2020 is that the drop in spending that we saw was entirely due to a drop in use of care. Prices, or the amount paid for a given episode or service of care, continued to go up. And in fact, in 2020, they went up a little bit faster than they had in the years before that. Next slide. So focusing more on price trends for the next few slides, we were able to use the APCD to get a look at growth in prices between 2018 and 2020 by category of spending. So to give additional insight onto where those price increases were primarily coming from. And as before, we found that the price increases were the largest in the hospital sector. When you're talking about hospital inpatient stays, over these 2 years, prices grew about 9.1% for a given stay in a given category. That was divided between about similar 4.5% growth each year, 2019 to 2020. And it's really not reflecting that much COVID care in 2020, which in the commercial market was a relatively small percentage of stays. And then we saw 5.8% growth in the hospital outpatient sector and smaller 3.2% growth over the 2 years for office-based services. And the next slide, putting that into some larger context, one way to think about, I just showed you the growth in prices, but where are we in terms of the level of our prices? And one way to think about that is comparing to the rest of the country. And we gained some insight into that from a recent study by the Congressional Budget Office, which compared prices across all of the states. And to break down what this graph means, what they did was they compared commercial prices and Medicare prices for inpatient hospital care, all to this national average Medicare price, which is the 100% average in the dotted blue line you see there. So what this means is that, for example, if there was a hospital stay that Medicare would have paid $10,000 as an average across the country for all the states. In Massachusetts, Medicare would have paid about $15,000 for that stay. You can see our blue bar, we actually get paid more by Medicare, our hospitals do, than all the other states in the country. And commercial insurers would have paid about $39,000 for that same stay. So that is way on the left, we're the highest among the states, according to this study. That's compared to, say, a state like Washington, where the commercial insurers would have paid about $25,000 for that same stay. Okay, and then on the next slide, we show that for physician prices, we are also relatively high among the states. We were about the 6th highest on average. Okay, next slide. And so that's looking at price levels and price growth for for a very specific stay. But we know that, as we've shown before, prices are also reflecting of where people are getting their care. There's a lot of variation. Prices are different across hospitals, and we've shown that before. So also contributing to our price growth is the fact that there was a shift over 2020 in what hospitals people are going to for their care. And particularly, you see in this graph that compared to a 2019 baseline, there was a bigger drop in volume across the community high public payer hospitals, that blue line on the bottom. That means that relatively more care was delivered in some of our more expensive hospitals, the AMCs, as you see there on the top. And so that also contributed, that mix in where people are going for their care, to overall price increases. And then on the next slide, bringing those trends together, we're just tracking in the long run average commercial spending per hospital stay for the entire state of Massachusetts. And so that is reflecting both shifts in site of care, as well as price increases, as well as even trends in coding, which we've talked about before. And putting that all together, we saw a 7% increase in spending per hospital stay in 2020. And with all these years put together, a 48% increase since 2013, from about $14,000 per stay to $21,000. Okay, I see there's a question from Tim Foley.
Yeah, thank you. Just before you got into the next session, just sticking with us for a second.
Sure.
Just on slide 37, I know we're saying that 9.1% price increase for hospital inpatient, 5% or 5.8 for outpatient, and 3.2 for office space. I know we talk about variation in price across systems, but is there a variation in price increase within systems as well that could be shown? So that, and what's the impact of those price increases on the total healthcare spend for hospital services by provider?
Right. There's absolutely difference in price increases across system. And when we are ready to discuss our price chart pack as part of this year's annual cost trends report, we should be able to show and discuss some of that. So I don't know those numbers right now, but absolutely there's price variation and in the increases as well. And so I think your second question is getting at the most recent slide I just showed is kind of taking all together all the factors in price, all the factors, boiling it down to spending per hospital stay. I think that's what you were asking, and that's displayed in that final graph of that 48% growth over the 7 years. Did that address? Okay.
It's also like the price increase by provider, depending upon which the level of cost to begin will have a bigger impact on the total healthcare spend for the hospital total healthcare expenses, just by system versus by aggregate.
Yes, I think you're saying, a given percentage increase would mean a bigger dollar increase if you're starting at a higher level, for sure. Mm-hmm. Dr. Berwick?
Is it possible to create versions of slide 37 backing out different components of the Massachusetts delivery systems? Could we do it, say, for example, if there were no academic centers or if MGB were not included? Do we have the analytic capacity to do that?
We do. And we have some slides from even not too long ago where we've shown those price levels, even by individual hospital as well as by cohort. So we can absolutely do that. And I'll just say that we can do that from our all payer claims database, which we often do. This data in slide 37 is ultimately comes from a RAND report study where we've shown some of those results before, and it's from a large set of self-insured employers who are constant across the country and comparing the prices they pay based on what state their employees are in. And they also do break down that data set by hospital. So we can share with that data and we can divvy it up any way we might want.
Thanks, David.
David, I was rather surprised that we were the number one in terms of the gap between the private rates and Medicare, because previous RAND studies have shown us not at the top of that list, that we were sort of in the middle at about 180%. So this is a different set of numbers.
Right. I'll say two things about that quickly, that you do sometimes get different rankings based on what underlying set of insurers the data are coming from, and we don't always come out on the top, but we are always high. And with respect to this graph specifically, it is confusing that sometimes people display our commercial prices divided by our own Medicare prices as that percentage. And that's not what we're doing here. And that'll make our commercial prices look a little bit lower because our Medicare prices are so high. So
yeah, because we get more higher pay for teaching. That's what
yes,
up our medical.
For teaching and geographic and other factors. That's right. So here we're showing both independently, so you can see. And if you wanted to do that division yourself, you could see where we would end up.
Chris, I know you have a question.
Yeah, thanks, Stuart. David, to Don's point about breaking it down by hospital type and trying to understand better the academic factor, I'd suggest we do it not just for ourselves in Massachusetts, but for the contiguous states. So as I read this and think of being an employer moving across the border to Connecticut or Rhode Island or New Hampshire, I see that I'm paying 50% more than approximately for my commercial rates, inpatient commercial rates in Massachusetts than I would if I moved my company across the border, and even more so in New Hampshire. So I think it'd be really useful for us to look at four states, not just one state, to understand the fractional intensity of having so much more academic care here. I think it would crystallize this discussion and reduce the noise that comes from trying to imagine how we compare with Iowa or New Mexico. But it's different in the Northeast for lots of reasons. And looking at those four states by hospital type, taking this graph, I think would be a very helpful tool.
That's very, very helpful. Let me remind our fellow commissioners that we will go into a lot more detail in subsequent meetings. So, David, why don't you continue?
Great, and thank you for that comment. Okay, so now I think we're into the affordability section. Okay, great. So just to remind folks, we've talked about this dynamic before as a cycle, whereby excessive spending driven by high and rising prices in the blue lead to higher premiums, higher deductibles, higher out-of-pocket costs, which in turn lead to adverse health outcomes and financial distress, especially for certain populations. And with that cycle in mind, let's look at some of the consequences for affordability as it played out in 2020. Next slide, please. So here we have 2020 premiums, again, compared as an example to the price of a new compact car. And as we saw from CHIA's presentation, there was an increase in premiums in 2020. Premiums were set prospectively, again, not knowing the impact of COVID, which would reduce total spending, but that increase that folks paid amounted to about $500 annually for a family premium. And I'll note on the right that left us about 7th highest in the country in terms of annual premiums at just about $22,000 on average, which is 3 times higher than they were in 2020. And that's just the average, but 10% of premiums for folks with employer-sponsored coverage were more than $30,000 a year, which is $2,500 a month. And that's more than a full-time salary for someone earning Massachusetts minimum wage this year, for example. Okay, next slide. And a survey, which we've shown before, taken in 2021, found that almost half of Massachusetts adults noted that they delayed or skipped care due to cost. And almost 10% reported that because of the cost of medical bills, they were under considerable financial stress, whereas 3 in 4 were worried about affording healthcare in the future. And I just also want to note that most of these responses are folks reacting to the out-of-pocket costs that they pay, which really are the tip of the iceberg in a way when it comes to total healthcare spending a lot of those premium costs are deducted by employers from total compensation and really not even observed by people. They just amount to salaries and wage increases that they never do get. Okay. And on the next slide, so in the same survey, again, we're showing that there were differential impacts in Massachusetts for residents of color, higher for those Black or African American or Hispanic and Latino residents, much higher. And on the next slide, a new survey by the census conducted since the beginning of the pandemic also highlights affordability challenges for Massachusetts residents that those premiums contribute to by taking away money that, as David Seltz said in the beginning, would otherwise be going to other priorities. So what this is showing is one of the questions the census asked was, did you have any level of difficulty paying for usual household expenses in the past 7 days? And they have this data they collected for every state in the country and at several time periods throughout the pandemic. So what I'm showing here is a couple time points for Massachusetts, first in August of 2020, and then just a month ago, January of 2022. And when you break that down by income, you see very high responses for the lowest income group in Massachusetts. About 3/4 say yes, difficulty paying for household expenses. But even in that second income group, of folks with household earnings from 50,000 to 100,000, who often have private coverage and who really struggle to afford that, 52%, and then that went up to 60% by 2022. It did not improve over the course of the pandemic, saying, yes, I have this difficulty. And that rate of 60% is even higher than the US average of 55%. We also saw increases in the 100,000 to 200,000 income group in Massachusetts. And again, much higher rates of problems paying basic expenses for Massachusetts residents of color, as you see on the right. And the next slide. And also adding to those, again, to those difficulties in affordability, we can look at premium increases. These are the prospective premium increases that are announced by the payer. So not the same as looking back, but looking forward. And in the small group merged market, we saw 7.9% increases in 2021 and even 6.9% for the prospective 2022 premiums, higher than in 2019 and 20. Okay, so now I think we're moving on to some insight that we have into what 2021 might hold. First, a couple of slides from national level data. This is an important slide showing national spending growth in the dark blue in 2019 of about 5%. Then we saw something similar to Massachusetts, where in 2020, total spending was just about flat, almost no growth, 0.2%. And in 2021, spending increased again 9.5%. So essentially, it's almost as if spending were just 5% growth each year, 19, 20, and 21, and you end up in the same place. So that's something to keep in mind. And I'm expecting that next year when we're sitting down for this hearing, we're going to have spending probably of a level in that ballpark. And then you see similar thing in hospital care and in physician and clinical care, same trend. And this is all payer. Now we can look at premiums in 2021 paid in the employer-sponsored private market. Growth there was 3.6% in 2021 after growing 3.9% in 2020. So again, similar to historical trends. You wouldn't know there was a pandemic and looking at these numbers. It all sort of gets smoothed out. And another important finding related to this is that among insurers, when they were polled about their 2022 rates that they were proposing or putting in play for the individual market, about 85% said, we don't expect any impact of COVID or a less than 1% effect in building in those rates. So that suggests, again, more support for the idea that by 2022, most of the volatility, at least insurers are saying, yeah, we think this is pretty much settled down. And we're treating 2022 as a year that's really business as usual, not affected by COVID. Okay, next slide. And this slide is showing, we've shown some of this before, but now we have the full year of 2021, that national hospital price increases were higher in 2021 than they had been in a number of years before that. Okay, and now let's turn to some of what we know about Massachusetts in 2021. You can move on. Next slide, please. Okay, it's probably a bit of a glitch. Are there any questions up until this point? Yes, Senator Friedman.
I'm sorry, I'm
Sure.
a little lost on the premiums 2021, which is current, have risen. So they've gone up. Did you say I missed that, 3.2 or 3.6?
3.6. I think it was 3.6 nationally.
Oh, okay, nationally. So we haven't looked at Massachusetts yet. Because what's happened to all that money that wasn't spent? Okay, are we gonna, is that somewhere in these slides, or are we gonna?
That's a great question. And I'm not sure that I have much more insight into that beyond some of what Ashley was talking about with CHIA. You know, some of it has gone into higher gains and surpluses for payers. Some of that will come back through MLR rebates over the next several years. Will all of it come back? I don't know. I don't have a good sense of that, but perhaps some other folks would know more about that. But but we haven't generally seen premiums going back down in 2021 or 2022.
Okay, so I didn't miss that on any of these slides.
No, and I apologize that some of what I'm showing is prospective and some of it is retrospective. For the most part, I'm showing past retrospective data, but I'll be careful if I'm talking about future premiums being set. Okay, okay. I think we're back to Massachusetts.
Yeah, good
other
question.
questions? Yeah.
David Cutler, you're muted. Okay, go ahead.
Yeah. So David, when you were showing the price increases there, to what extent were those adjusted for the case mix of the patients? So I'm wondering, is that just because they were restricted to very, very severe patients like COVID patients who are in the ICU for a long time, or are those risk adjusted?
That's a good question. And I'm not, this is data reported by the Alterum Institute, and it is based on a producer price index, which I think is ultimately from the Bureau of Labor Statistics. And so I don't think that those are really case mix adjusted, but they are more reflecting what hospitals are charging for services. So some of it is in there, but it's also true that the commercial market is less affected by COVID, both because most COVID patients have been older and on Medicare, and also that a lot of the supplemental price increases, CMS did some of that, some states did some of that. The commercial market didn't necessarily follow that trend. So I don't think that there's that kind of a direct impact of COVID in most of the prices that we see. There could be, we suspect that a lot of the COVID related impact is more in the negotiating leverage and dynamics that go on behind the scenes. And perhaps I think that Aditi will be talking a little bit about prices and some of those underlying dynamics.
Don?
Yeah, David, thank you. This is wonderful as usual, but can I go back to Senator Friedman's question? I just want to make sure I get the answer straight in my head. It's a little confusing. So utilization went down.
Yes.
Prices went up. The insurance premiums stayed, rate of rise stayed about the same, but the proportion of insurance retained as surplus went up. So where's the money? And the answer appears to be it's in the hands of the insurers. Is that the implication of this sequence?
I can speak to that as well, David. If you don't mind
Let's let
jumping
Ashley,
in.
yeah, because
You want to jump in?
but I will make one comment that there's a difference between the self-insurance market and the fully insured market as well as we think about this, and that where self-insured firms are paying ultimately the claims, like the GIC, they are the ones saving the money in 2020 from that reduced utilization directly. But in the fully insured market, it's the dynamic that Ashley was showing where there is that greater retention. And maybe you have, please go ahead if you have any more thoughts about that, because I don't have the answer.
Yeah, I mean, that's a great point. So for 60% of the commercial market that are in self-insured plans, it would be the employer plan sponsors who were benefiting from medical costs being lower. For the 40% of the market that is fully insured, those gains were captured by payers. I would defer the DOI on what happens with that. I know they monitor, insurer reserves really closely, and that there's a certain amount of money that needs to go back into reserves to keep companies solvent. And then, as I mentioned earlier, the federal MLR formula, because knowing that there is a certain amount of instability in the market, it looks at 3 years of data at a time, which means that these most recent rebate payments were based on the 2018 to 2020 experience. So if some plans had losses in those earlier years, those would have been, buffering the 2020 rebate amounts. But we may see in 2021 more of the impact, and we may see larger rebates. I don't want to speculate too much because I know that data hasn't been submitted yet. The DOI will be reviewing it in a few months, but that would be something to be on the lookout for.
Representative Barber.
Thank you. And just going along this line of questioning, I appreciate the question. And for me, in looking at, 2020 was such a highly unusual year because of the pandemic and how much costs went down, and also consumer use went down in some ways. So I think what I'm struggling with is a disconnect between what we're seeing and how much consumers actually had to pay. And I appreciate the work that CHIA presented about cost sharing and what folks are actually paying and how that's affected. But I think in this question of where is that money, it's hard to say, did some go back to consumers, to patients? Did patients spend less money and that's why there is more money? It's hard for me to get at what does that mean for people's budgets and actual people on the ground in this whole question. So I don't know if there's a question there, but a concern about kind of the disconnect between this overall looking at costs and what that actually means for what we're all spending on premiums and on cost sharing.
I couldn't agree more with those questions. Can I ask both David Auerbach and Ashley Storms for you guys to put your heads together and to sort of look into this in more detail, and maybe at a future meeting or in a report, go into some understanding of the best we can on where that money went. I think it's a very important question, both for us and for the legislature, because it sort of leaves a kind of a gap in our knowledge base. But with that said, let us, Tim, you want to have the final question, because I'm.
No, and I was channeling you when I knew when I raised my hand. So we got to keep the agenda moving, which I think is right. And I was going to ask Ashley, in reading the private commercial insurance slide that was presented on the fully insured non-medical expense components and surplus, is it right to suggest that the $19 per member per month went back to profits? That's how you're separating it out, right? It was $85 that was divided amongst all those different categories. And of all those categories, what's left over is $19 per member per month for the fully insured market went back to profit.
So essentially how we developed those numbers is we took the federal medical loss ratio reports that the plans submit, and we looked at the money that they reported in premium revenues, and then we subtracted out all of the allowable expenses that are reported on that form. And so that $19 per member per month is what was left over. We don't have, unfortunately, more insight into what happens with that money after that. I'm sure the plans would list many programs that they use it on, but we just don't have that information on the forms that we use.
Thank you. And that's a net of the rebates as well.
That's after rebates, yes.
Okay, David, did you have some more comments? David Auerbach?
With me. No, I think nothing more on that. Well, maybe one more thing on that topic. I would just note that as we showed before, that from the Alterum Institute, that national spending was flat in 2020 and then it grew 9% in 2021. And so, you know, the premiums are to some extent smoothing that out. You know, we're not seeing a 9% jump in 2021, at least in that national number. So they're kind of smoothing it out, but I will work with Ashley to see if we can understand more of this situation.
Well, that gives us a good segue into our keynote speaker.
Oh, I do have one more section,
Oh,
actually.
you do have, that's what I was asking.
Yes, sorry, I didn't know where you were going. I do have one more section, that's right.
Okay.
And I'll try to go fairly quickly.
No, that's all right.
Yep, okay, great, thank you. So finally turning to some things that we know from 2021 in Massachusetts specifically. We do have data, as Ray suggested in the beginning, we do have data that's quite recent regarding ED visits and hospital discharges that's reported by the hospitals. And so this gives us some more sense of this, you know, down and up effect of the pandemic. Here we're looking at just visits from the March to September period over the last 5 years. And in the ED, we saw this big drop in 2020 in ED visits of about a third. And then in 2021, they come back up. And over the course of the 2 years, there were still 11% down from 2019, but most of that volume is coming back. And then in hospital discharges, the same sort of pattern, 13% down, 9% up, and a net reduction of 5% over the 2 years. Okay, next slide. An important note that's getting at some of the additional workforce challenges that we're seeing in mental health challenges. We have seen a growing rate of this problematic trend of behavioral health patients coming to the ED and then being boarded there for a long time. So this is showing of those behavioral health patients in the ED, what percent of them were there for more than 12 hours. And that has grown from about in the high 20s in 2019 to now about a third as of our latest data of September 2021. This slide is going back to the spending trends. We do also have some insight from the GIC, which is collecting and reporting data. Now note this is on the state fiscal year, so they are showing their spending and prescription drug trends from June to June, basically. So they saw, again, no change in 2020 relative to 2019, and then double-digit growth in spending in 2021, both in medical and in prescription drug spending. And that drug spending is not net of rebates, but it is gross spending. Okay, and a couple more slides. Again, continuing showing some of the hospital finances from what CHIA showed before. They did report some data as of June of 2021 for the 9 months previous, and we can compare that to the last 6 years or so. And here you see that drop in margins in 2020, and then some recovery in 2021. And note that this does not include the impact of the Delta and Omicron waves that came later in 2021 and into 2022. And there's a lot of variation within these numbers by hospital. But from 2020 to 21, there was an increase in expenses of 8%, but a higher increase of net revenues of 16%. And another important data point as we're thinking about just the volatility in the healthcare sector overall caused by the pandemic. And what we're showing here is some interesting trends in both employment and in wages for several healthcare sectors. What these numbers mean, for example, if you look at the offices of physicians on the left, what they are showing is that compared to 2019, employment in offices of physicians across all workers dropped 16%. And then by 2021, that employment had come up so that it was almost back to the 2019 level, still just 3% down. And the next two bars are showing the wage changes for those workers in 2020 and 2021. 3% increase in 2020 and 8% increase over the 2 years from 19 to 21. So that pattern of drop and then recovery you see throughout, but I especially want to note the home healthcare service sector, and then the last two, the psychiatric and substance use hospitals and nursing care facilities, which had double-digit drops in employment even in 2021 compared to 2019. Those sectors were really challenged by the pandemic. And you see wage increases of double digits in both years, suggesting that they are really suffering from a shortage of workers, big drops in employment, big increase in wages. And those do have ripple effects through a lot of areas we're seeing in the healthcare spending data. Okay, so there, I'm going to turn back to David Seltz, and then we'll be ready to move on to the guest speaker.
So just to wrap this up and returning to this vicious cycle of spending increases leading to unaffordable care, leading to adverse health outcomes, we've spent a lot of time thinking about how we can turn this into a virtuous cycle. And so want to highlight for the Joint Committee on the next slide that we recently released our 2021 Healthcare Cost Trends Report, which includes a set of policy recommendations, which we believe will really chart a path for the future to be able to make sure that we succeed in addressing these intersecting cost challenges of cost containment, affordability, and health equity. I have a number of areas of focus that we are enthusiastic to work with the legislature to advance. And these efforts matter for the residents of the Commonwealth in real ways. And on this final slide in our presentation, we just did a thought exercise to show how reducing a modest reduction in the growth of healthcare spending growth can have real impacts on families' budgets. And so what we did as a thought experiment, we said if Massachusetts healthcare spending grew at 3.1% annually versus a recent trajectory of 4%, by the end of that period of time, total healthcare spending would be reduced by $8.3 billion. Family premiums for Massachusetts residents would be 6% lower. Workers would have over $5,000 more in take-home pay during that time period and have less out-of-pocket spending, all of which would lead to less avoided care due to cost and fewer financial harms. So modest reductions in the growth of healthcare can have significant positive impacts for Massachusetts families. And this is why it is important to maintain our urgency on healthcare cost containment. So with that concludes our HPC presentation. We're excited to turn it over to our keynote expert speaker. And we'll turn it back over to Stuart Altman, who I think will hand it off to our vice chair.
All right, thank you, David. It's my honor to introduce our keynote speaker, Dr. Aditi Sen. Dr. Sen is the Director of Research and Policy at the Washington-based Healthcare Institute, a leading nonprofit research institute focused on healthcare markets, payment systems, and the implication that these systems have for equitable access to care. Dr. Sen is an adjunct assistant professor in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health, and is a gubernatorial appointee to the Healthcare Spending and Benchmark Subcommittee of Delaware's Economic and Financial Advisory Committee. She has served as a health policy fellow in the U.S. Department of Health and Human Services and was on the staff of the White House Council of Economic Advisors. It gives me great pleasure to welcome Dr. Sen.
Well, thank you so much for having me here today. I'm really excited to participate and especially appreciative to participate in this really important work that Massachusetts is doing and leading across states to contain healthcare spending and improve affordability. And I'm especially honored to be here in part because I've been for a long time a user and very appreciative of just the incredible data, resources, and attention that is paid to tracking healthcare costs and drivers and addressing high healthcare costs in Massachusetts. As I said, it's really a model for a lot of states, but also personally because I was born and raised in Boston. So it's really a personal pleasure to get to be part of this effort. So what I want to do today is to kind of offer a national perspective on healthcare prices and spending. You can go to the next slide, thanks. I think, so first what I'm going to do is I'm going to talk a little bit about kind of the role of prices in driving spending nationally and why high prices matter. And then I really want to kind of highlight a few specific dimensions of prices that I feel are places to watch, where I think we're seeing some especially concerning trends. And then I'll touch on some state actions, what other states are doing in this space to address high prices. Again, many modeled after your state. And then wrap up by kind of taking a step back and looking again at the big picture and taking this kind of long view of healthcare spending. How should we see prices and spending in the context of COVID, as we've been discussing, some of the trends in use and spending over the past year, that some of which we've seen already today, and kind of how we expect these trends to evolve going forward. So as you all know, and has already been highlighted today, healthcare prices in the US are high and also very highly variable across almost every dimension you could think of. As shown in the figure down at the bottom, in a study of US prices for hospital and physician services compared to other countries, with only one exception, other countries' prices are lower than the US price for this range of sort of different hospital admission services and physician outpatient services that are listed on the left. So the US price is shown as 100% of the price. That's a line of red dots. So basically prices to the left are all lower, a smaller percentage of the US price. And so you can see that kind of massive multicolored dots. Other countries, the UK, Switzerland, Holland, Australia, New Zealand, South Africa, and UAE, all for the most part to the left, so lower prices than in the US. So prices vary across countries, but also within the US, within across hospitals and payers, within markets, within hospitals across payers, within hospital systems across hospitals, but also across settings. For example, and we'll come back to this, but looking at kind of the same service provided in an outpatient department versus a physician office, and of course across payers, as Dr. Auerbach was talking about, thinking about, for example, the comparison between commercial prices and Medicare. And what the evidence is showing, and there's sort of growing literature in this space, there's sort of always emerging work coming out. I think the kind of takeaway to date is that the link between price and quality is certainly not clearly established and varies a lot across markets and hospitals. And what previous work has shown is that there are a lot of high quality hospitals with relatively lower prices. And that further, that this price variation that we see is not really explained by patient severity or case mix. I can go on. And so I think, given that prices don't seem clearly linked with quality or patient complexity, from my view, I think this really raises the urgency to understand what drives high prices and in what situations we may need to use policy tools to lower these prices and improve affordability. And as we've been talking about in the last presentation, how do these kind of high costs and high prices really translate into what consumers feel, what patients feel, what families and workers are experiencing? And I think there's a lot of different reasons why high prices matter. Of course, they're a barrier to accessing needed care. As Dr. Auerbach was showing, there's very close connections between higher cost sharing amounts, higher prices, and the ability of people to get the care that they need, the drugs that they need. Also, high prices translate into higher premiums, less generous insurance, and lower wages. So there's sort of these ripple effects across different industries from higher healthcare prices. High prices exacerbate inequities in healthcare access and outcomes. So we know that low-income individuals spend a substantially greater proportion of their income on out-of-pocket costs for healthcare services and health insurance. And just some very recent data from the Kaiser Family Foundation showed that about half of households nationally don't have enough liquid assets to pay a typical employer plan deductible, and almost 2 in 3 households don't have enough resources to cover a higher end deductible of private health plans. So these high prices really translate into costs that are felt by individuals. At a kind of market level, they also affect the structure of healthcare markets and firms. There's a good amount of evidence now that sort of higher prices, for example, higher prices in outpatient settings and office-based settings can incentivize vertical consolidation between hospitals and physician groups, which in turn raises prices further. So it can really kind of affect the structure of healthcare markets. And as has been mentioned here as well, diverts resources away from other sectors. And I think importantly also creates these kind of incentives to construct workarounds that have broader implications for consumer access as well as healthcare markets and spending. And I think a great example is our drug copay coupons, where these drugs have very high list prices, and copay coupons sort of take some of that out-of-pocket cost off of people, but doesn't really do anything to address the actual high prices of those drugs, which continue to drive up spending. So I think there's a lot of different reasons to think about how we can address these high prices. So what we're seeing, I think, pretty consistently nationally is that rising prices are really the driving force behind increasing healthcare spending. So at the Healthcare Cost Institute, we have a commercial claims data set that we assemble and manage in-house and make available to external researchers as well. And every year we use this data to look at healthcare spending per person on inpatient, outpatient, professional services, and on prescription drugs. And our most recent report is looking at 2019 data. Our 2020 data and report should be out this spring. But what we saw in 2019 is that healthcare spending per person rose to over $6,000 per person. So it's a per capita measure. So over $6,000 for the first time. Over that kind of 5-year period leading up to 2019, spending grew about 22%. And 2/3 of this increase was due to growth in prices. And so what we do, and you can see in the figure to the right, is we take this kind of total change in spending, which was $1,079, and we divide it up into the different factors that contribute to healthcare spending, right? So there's price, there's inflation, there's of course volume, sort of use of services, and then there are demographic factors and service mix, which is sort of the within, for example, outpatient setting, the composition and mix of services that are being provided. And what you can see when we divide up this total change in spending is that about 2/3 of the increase is due to this growth in prices. That's that top bar. And so this is by far the largest component of spending change, and a lot bigger than the increase, for example, in volume. And what we saw in that same report is that prices are really first of all, prices are going up across all sort of types of services, and they're really driving spending. And so in the left panel, you can see utilization, that's the dotted lines, and average price, those are the solid lines for overall in the black line, and then professional services, prescription drugs, outpatient and inpatient. And then you kind of put those two things together and you get spending. And so spending on the right is going up across all these services. And you can see kind of that from the left-hand panel, this is really driven by prices. And I think, and I'm going to come back to this, that the inpatient example is sort of the most compelling and kind of glaring, I think. So, the inpatient, over this 5-year period, inpatient use went down 12.5%. Spending went up 14%, and that's entirely due to this 31% increase in average price that we see. So, we've had this kind of big picture of how prices are driving overall spending nationally and over time. And now I want to get a little bit more granular and highlight a few specific areas of prices that I am particularly concerned about. And I think where we need to keep an eye on these prices and also think about ways that we can use our policy tools to address some of these trends. And so the first situation are prices in cases where service use is declining and prices are still going up. And kind of generally in these cases, what we're seeing is that we're paying more for fewer services. And I think for the most part, the evidence does not suggest that we are getting higher quality or better outcomes for these higher prices. So I think we have reason to be concerned. So the first example is this inpatient services example that I was talking about on the prior slide, where we see use going down about 12.5%, prices going up 30%, and so spending is going up. Another area where we see similar patterns is in ER services, and that's the graph on the slide that you can see, where we have utilization, that's that kind of gray bar at the bottom, going down, not a huge amount, 4% going down. But prices, which is that red orange line at the top, went up 58%, and this led spending to go up 50% in this 2012 to 2019 period. And again, in the HCCI data. And what we also see is that coding of ER visits has shifted towards more severe, higher priced codes. And so I think, this suggests to us that there's some amount of upcoding that is leading also to this kind of driving up prices. Is this sort of a coding move towards sort of more complex coding? And these are just the evaluation and management kind of lines of the ER services. So basically, it's just the price to walk in and see a physician. And then the third area to highlight are physician-administered drugs. And there's some growing attention to this set of injection infusion drugs. And what we see in our data is that the average price of administered drug nearly doubled over the 2014 to 2018 period, and that the increase in spending on administered drugs accounts for almost 40% of the total increase in physician spending that we see in our data from 2014 to 2018. So I think this is another area where we're going to see increasing attention. We have to think about ways to address the high costs of these drugs. Another sort of dimension of prices that I want to highlight, which we talked a little bit about in the previous presentation, is this high and growing differential between public and private prices for healthcare services. And so, we know that prices paid by private health plans are higher and they're growing faster than prices paid for the same services by Medicare. And using that same report that Dr. Auerbach was citing, this RAND report, they find that commercial insurers paid almost 250% of what Medicare would have paid for the same services at the same facilities. And that's up from 224% in 2016. So it's increasing. And a recent report from, again, Kaiser Family Foundation found that over 50% of inpatient admissions are now paid above 150% of the Medicare rate. Almost 33% are paid above 200% of the Medicare rate. So this differential is, I think, is really something to think about and think about kind of what is driving these inpatient prices in particular up so much. And I think it's also important to keep in mind that it's not just the private firms paying these high prices. It's also, as this group is especially well aware, is also, for example, state governments, and they're covering their state employee populations, teachers and municipal employees and others. And I want to note that I think that Medicare is a useful benchmark for prices for a number of reasons, but not necessarily an endpoint for private prices. I think some nice things about Medicare rates are that they're comparable across hospitals. They take into account regional and clinical factors. And I think importantly, the process for really setting and understanding the Medicare prices is fully transparent. So we can see kind of what the different components of the Medicare rate are. So the third dimension of prices I want to note are the differences in prices across settings, which I sort of hinted at earlier. So as MedPAC has noted and studied for quite a while now, leading towards this kind of movement towards site neutral payments in Medicare, is that there are really pretty substantial differences in the price of healthcare services, depending on the setting where the services are performed. And in particular, that services performed in a hospital outpatient department tend to be much more expensive than the same services provided in a physician's office. And they determine a set of services where they judge that these services can be appropriately and safely provided in a physician office. So obviously not everything done in an outpatient department can be done in a physician office, but they identify this set of services that are safe and appropriate when provided in an office. And so what we did with our HCCI data is we took these, the set of services, and we looked at the sort of difference in prices for these services across setting, and also at the share of the full set of each service that is provided in a outpatient department versus an office and how that's changing over time. And so what we found is that in all cases, outpatient prices were higher for all services than office prices for the same service. And also that services are increasingly shifting towards outpatient departments, which drives up costs overall. So what you see on the slide in the figures is the trend just for one service, for drug administration. And on the left, you can see that the percent of services provided in an outpatient department has doubled over time from 23% to 46%. And on the right, you can see that the office-based price over time in the blue is a lot lower than the outpatient price, which is in the red, and which is not just higher, but also increasing more quickly. And so I think that these site-based payment differentials raise concerns, of course, about patient affordability, right? A patient might get referred to a hospital-based provider, even one off campus, who they may not know is affiliated with a hospital, and they may pay a lot more for a service that they could have gotten in a physician office safely and at a lower price. And there's also evidence that higher outpatient prices drive vertical integration, which again, as I said before, further drives up prices. So that's kind of the market level effect. Go on. And so another dimension of prices that I want to highlight is the sort of variation of prices across hospitals within systems. And I thought this was quite remarkable. I mean, we see really remarkably different prices across hospitals within systems. And again, this is from that RAND study. And what the figure shows is the distribution of hospital prices relative to Medicare across hospitals within a number of large systems. I do think Partners is in there somewhere. But I think sort of generally the takeaway from the height of the boxes, which show the 75th percentile of prices and the 25th and then the median, is that there's just a lot of variation within systems across hospitals. And in fact, in the average system, the hospital with the high 75th percentile price has prices that are almost a third higher than the hospital with the 25th percentile price. And so that suggests that prices vary even more within a system than across systems in some cases. And then I think this is the final sort of piece of specific price issue I want to highlight. And this is an area of growing interest, the impact of private equity acquisition on healthcare prices. And so there are, I think, some really nice recent papers that are coming out looking at the impact of private equity acquisition on healthcare prices in sort of a range of different settings. And essentially what they all find are increases in charges and prices following acquisition by a private equity firm. And so the first paper looked at acute care hospitals acquired by PE firms. They find increases in hospital charges and charge to cost ratios. They do find increases in case mix index, which they link to potential upcoding, and also a reduction in the percent of patients discharged who are covered by Medicare, which is just an increase in the percent covered by sort of higher reimbursing private insurance. Similarly, among dermatology practices that were acquired by PE firms, they found that prices paid to dermatologists for routine medical visits were 3 to 5% higher than those paid to dermatologists who were not part of these firms. And then a really pretty recent paper among looking at anesthesiologists after an outpatient facility contracted with a physician management company. Allowed amounts increased by 16.5. That's the amount that insurers pay. The unit price increased by almost 19%. And in particular, when the physician management company was PE backed, prices rose about 26% compared to 13% when not. So I think these changes in price and charge and costs could reflect a number of different factors, right? So they could reflect that they're charging more, they're maybe cutting operating costs or some combination after the acquisition. But I think as we're seeing these trends in PE acquisition it's really important to be aware of how they're impacting prices and in turn affordability and access. So when we kind of take a step back and think about what is sort of leading to this upward pressure on prices we're seeing, I think there's sort of a number of different factors that come into play. One is, of course, increasing consolidation in healthcare markets. And there's just a ton now of really convincing evidence that horizontal and vertical integration among healthcare providers is associated with higher prices. There's this growing role of private equity that we talked about. And also, I think on the other side of the market, so there's limited leverage by insurers and employers to kind of counter the very consolidated provider markets. We did a study of large self-insured employers and basically found that almost nowhere do these even large employers have particularly concentrated market power when we think about them sort of sitting on the other side of a negotiating table with providers. Just as kind of an illustrative fact, the mean value of our employer market power measure was 62 for 2016, compared with a mean value of 5,410 for hospital market power. And for those who know how we calculate these market power measures, it's an index. So basically this fact is just to show that there's a very different kind of market power and leverage sitting on either side of these negotiating tables, and that really employers don't have a ton of ability to negotiate lower prices. We, as I said, increased prices translate into higher premiums, but these effects are kind of dampened because premium contributions by employers versus employees may not be really salient to individuals, and also they're generally excluded from taxes. So that link is it's direct, but it's not that salient, which allows for more price increases. And similarly, the links between higher provider rates and labor market outcomes like wages and health insurance offerings, for example, narrower benefits are also indirect. And so all of that allows for this kind of upward pressure on prices. So when we think about kind of what action state policymakers are taking to lower these prices that we're talking about, I like to kind of think about these sort of options for state policymakers and what we're seeing across different states, and kind of a continuum of efforts to lower prices as the objective. And I think they kind of fall in two buckets. One is sort of indirect approaches. That includes things like price transparency, cost growth benchmarks, insurance regulation and design, like rate review, which we see, for example, in Rhode Island. And of course, efforts to improve provider market competition where that's feasible. And then at the other kind of side of the continuum are direct approaches, which are essentially price caps and regulations, not necessarily statewide or for all providers, but we could think of it, price caps or some sort of price regulation for certain populations, like state employees, public option enrollees. For example, you could think of Washington, where they have a reimbursement cap. You could have caps we've seen caps for specific services. Of course, out of network is sort of the big example of this, but also facility-based services. You can also have caps on providers, for example, high-price providers. And in any of these contexts, of course, there's a lot of different options for the structure and the level of the cap, and states vary in how they're thinking about these kinds of caps. I want to highlight that there's a really central role for data and analysis in all of these efforts. And in general, when we talk to states, they say, well, we don't really know where we are in terms of our current baseline prices. I mean, we're not Massachusetts. We don't have that level of data capacity. So, I think I just, want to highlight that really the kind of data and capacity that that your state has built, and this sort of ability to use data for policy is really unique, and it's a model for a lot of other states. And it really underlies any of these approaches. So as I've already sort of talked about some of these examples, but there are states doing taking action, along this continuum from healthcare spending benchmarks in a number of different states, health insurance rate review. I think Rhode Island is kind of the poster child for this, where they impose inflation caps and diagnosis-based payment on their insurer provider contracts run out of their insurance commissioner office. Premium reductions, requirements in a public option setting is what we're seeing in Colorado and Nevada. And then on the direct side, we have states that are, a lot of states are regulating rates for out-of-network healthcare services with a mix of kind of payment standards, arbitration, and how those policy efforts are set up and designed has kind of ultimate implications for overall effects on rates. We have states where they are benchmarking prices to Medicare and in a public option setting. Again, that's Washington. And then a couple of states where they're thinking about and implementing benchmark pricing in their state employee plans. I think Montana and Oregon are kind of the key examples of those. And I think in both states, there have been sort of reported savings from that kind of benchmarking. Okay, so there's a lot of action going on at the state level. It's really an exciting space to think about what all the different sort of policy tools and levers. And now I want to sort of wrap up by taking kind of a step back to take this kind of long view of healthcare spending and think about how this sort of pandemic era trends that we've been discussing fit into sort of longer term perspective. So what we see here are national health expenditures, actual, I think through 2019 and then projected. And I think so this shows, the total spending on personal health care, that's the top black line. Then these are sort of healthcare services that individuals receive. That's what we mean by personal health care. It's projected to continue to rise, hitting over 5 trillion by 2028. And then you can see all the sort of different components of personal health care below that. So hospitals are, as we have been saying, kind of the biggest component of spending and expected to continue to be. Below that is physician spending, professional spending in the green, and the orange dotted line, which I see now does not have a label. I'm sorry about that. Is home health care, nursing care facilities, other residential care. Then you have prescription drugs in the red line, and then other medical products in that blue dashed dot line. There is somewhat faster growth in prescription drug spending anticipated due to faster increase in drug prices and sort of acceleration in the use of and intensity of services. But otherwise, in some ways, I think the kind of notable takeaway is that not too much is expected to change at this point in the long run without kind of major shifts in how we pay for or provide care. So, we've talked a little bit about this, and you've seen some of these data before. But I think overall, I think sort of the kind of pandemic effect, of course, still sort of the holistic effect still remains to be seen, in part because we're still sort of in it. But from 2020, I think what the data is sort of starting to converge on in terms of a conclusion is that the pandemic led to a major, but somewhat temporary drop in service volume. And so we see here, this is year over year change in healthcare spending in the black line, and the use and price component of the change in the blue bars is price and the green is use. And so of course, this really substantial drop in use is clear. Over this period, use fell dramatically and the prices have continued to increase. Those are those sort of blue bars. So that's not changing too much. And even by August of 2020, we were almost back to pre-pandemic levels in terms of spending. The use was still about 4% lower than in the previous year. And so I think this raises the question of, when use will be back to contributing to spending growth, and to a certain extent that remains to be seen. And I think, as Dr. Auerbach was saying, these kind of pandemic effects, this sort of effect on healthcare spending and use, varies a lot across hospitals. And so I think, which hospitals are going to face kind of lasting revenue drops is going to be important to kind of think about for different categories of hospitals, and that addressing those cases is going to require probably a pretty targeted approach, not kind of a economy-wide or even a statewide approach. You can go on. Okay, so when we look, I think, more closely at prices, the national data suggests that private sector prices for care are continuing to rise, as we've talked about, and as Dr. Auerbach talked about as well. So, for example, you can see in that sort of top figure shows, Medicare, Medicaid, and private insurance year-over-year changes in hospital price. And I think the kind of takeaway is that hospital prices for care paid by private insurance increased by a little over 4.2% in January. That's a pretty steady rise from October of 2021, when the rate was 2.9% year over year. And I also want to highlight, I think there's been a really, really important role for government assistance in kind of buffering the effects of this decreased revenue for hospitals. And that the sort of government assistance played a really key role in the kind of recovery of healthcare spending that we've been seeing. And so these sort of small graphs at the bottom essentially show that for physicians on the right and hospitals on the left, the drops in spending that would have occurred without government assistance in red were essentially buffered by assistance, so that spending on hospital care and on physician services essentially exceeded the January 2020 level by December 2021. And as we've been talking about, among these healthcare components, hospital services are the fastest growing in terms of price growth, but we also do see that prescription price drug growth is also positive in January versus a year ago, which sort of ended a streak of negative price growth. So I know that is an area where the state is also seeing growth. So, we've spent some time considering the role of prices in driving healthcare spending nationally over the past few years, as well as I think how kind of pandemic era trends fit into this longer view of healthcare spending and the role of prices. But I also highlighted a few areas where I'm especially watching and, thinking about how we might address high prices. And so, to summarize, I think much of our work at HCCI, as well as by many scholars, shows that prices for healthcare services can continue to rise. They make healthcare unaffordable, especially for lower income Americans, and that they are really they're really driving the increase in healthcare spending overall. And some of these sort of key areas to watch are hospital inpatient prices, ER prices, and prices for physician administered drugs. The NHE data and some of that BLS data that I was showing also suggest that prescription drug spending is rising due to price increases. And then I think trends like this sort of shifting care to higher priced settings, whether that's the office to outpatient department or lower priced hospitals to higher priced hospitals, that kind of shifting care is also something that is driving up prices and spending. And that another factor in this might be upcoding. We see this particularly in ER settings, but I know that HPC and others have done some work on this as well in Massachusetts setting. So I think that, when we think about efforts to reduce prices, which is of course necessary for reducing healthcare spending and increasing affordability, I think that there are sort of two important final points that I'd like to make. First, that the evidence generally suggests that when faced with lower prices, hospitals reduce costs and become more efficient. And second, that there are a range of options that states are considering implementing to control healthcare costs and improve access to an affordability of service. And of course, that includes this important work that your teams are doing in Massachusetts. So I really thank you again for inviting me to be part of this meeting today and to participate in this work you're doing.
What a fantastic presentation, Dr. Sen. That was wonderful. I know we're running a little tight on time, but I want to really give the option to our representatives, both from the House and the Senate. If they have any questions, I would ask our fellow commissioners. We can discuss these in depth at a future meeting. So Chair Friedman or Chair Lown, are there any questions or comments you have or your members?
Thank you, Dr. Albert, and thank you so much, Dr. Sen. This was really interesting. It's what the sort of trick is for me is, where does Massachusetts fit into this? Because I think we are in many ways either dealing with these things right now already, like they're on our plate and we understand them, or they're sort of part of our ecosystem already. I have two just quick questions. One of them is that in one of your slides, it was 68, I think it was, usage was down 12.5, but prices were up 30. And this question kept coming up for me. When the usage, which is the number of people using the services, does that take into effect the level of acuity? So, and is it just, do you just say, well, they're upcoding, or is there a way that you can actually tell that actually, we would think usage would go down because more people have better care. They don't need to go to the hospital as much, but when they do, they could be really sick. So in all of these numbers, is that kind of analysis done, besides just saying it's upcoding, which we get, I think, or I get anyway?
Yeah, I mean, that's such a great question. I actually can't, I think I have 4 meetings over the past week and a half about talking about how to make this adjustment and how we can tell apart upcoding from, real changes in practice or real changes in patient complexity, which, certainly exists. So let me say 2 things. So one is that, so first, in this case, when we talk about use, we're talking about the number of services. So not people. So of course they're related, but it's a number of admissions, for example, in the case of inpatient. But it's still true that, of course, like those admissions could be getting more complex or be more severe. So what we try to do in this report is we look at the sort of shift in, we try to pull out the shift in codes, which not upcoding, just kind of what's the sort of mix of services being provided, and try to pull that out of the price estimate. So essentially we can say, for example, if the basket of inpatient services in 2019 was the same as 2015 in terms of the types of services provided, what is the price increase we're looking at? And that's what this price increase measures. So we're trying to hold the sort of mix of services constant, but I think that still allows, like that's still subject to coding, right? Because we're still using the hospital data to tell us how they're coding it. So it's certainly not perfect. It does not, really allow us to tell what is upcoding and what is sort of real shifts upwards in complexity. But we do try to hold that constant to pull out this price number.
Okay. And then 2 other, these are quick questions. On the pharma piece, are PBMs in any of those numbers? Does PBMs exist anywhere in this price comparisons?
Well, what I would say, so as you know, like trying to figure out who pays what at each step of the pharmaceutical supply chain is almost impossible. Yeah. So, the way that I try to think about it in our data is that we're seeing what the patient pays. So essentially all of that is kind of baked in, and that's kind of, so you can see it like if you look at brands versus generics, or you look at brands with a lot of competitors and brands with fewer competitors, where we would expect something like PBM influence to be more or less active, but we can't pull out, how much of the price is PBMs versus rebates versus wholesalers. Right?
Okay. And then in outpatient, when you talk about outpatient, are you talking about hospital outpatient? You're talking about ambulatory care services? You're talking about the whole thing?
Yeah. So when we talk about outpatient in our data, for the most part, and in that kind of where we break it out by inpatient, outpatient, professional, that is the outpatient facility. So it could be an urgent care center. So it's not just hospitals, but it is mostly hospitals, and it is the facility component. And even for an outpatient service, the professional component would be in the professional line. So that's how our data are broken out.
Thank you so much. I don't know that any of other senators have questions.
Okay. Well, if they do, let me know. If not, David Auerbach, I know I saw your hand up.
Oh, I did. Thank you. Yes, I also wanted to just address the first point that Senator Friedman raised about this, about hospital admissions and acuity. We did spend a lot of time in our 2019 cost trends report looking at exactly this, where we first documented that rise in coded severity of hospital patients for the last 5 years. And we worked very hard to try to see if there was anything real or anything behind that with regard to were these patients getting sicker. And we really didn't. We looked at length of stay and there was essentially no change. We looked at use of ICU or intermediate intensive care over this time period, and there was no change in that either. And we also, we looked at whether lower acuity patients were leaving the hospital and being treated in outpatient settings, leaving a sicker mix behind in the hospital, and we did not find evidence supporting any of those explanations. And so we concluded that it looks like most of this trend is not true acuity, but really changes in coding practices.
Thanks.
Well, okay, that's, permit me to make one comment, which I've been involved in this area for a very long time. And if you look back over a 50-year period, there's been a lot of talk about how we develop a more efficient delivery system, how we move people, as Senator Friedman pointed out, how we move people from inpatient to outpatient, how we try to be efficient. But I think the conclusions of Dr. Sen and David Auerbach and the CHIA is that we face collectively 3 factors that are not easily dealt with by just moving patients around. One, the biggest growth is in prices, not utilization. 2 is this growing trend of both consolidation, but the most recent of the Dr. Sen has pointed out the fact that we're now seeing a lot more private equity. And we have in Massachusetts the purchase of Atrius by Optum as a concern. And third, this issue of upcoding, which distorts so much of what we see. And it's difficult to sort of separate it out. I think suggests going forward that we in spite of what you said, Chair Friedman and myself, we're not well equipped as well as we need to be, I think, to deal with those 3 areas. They are very difficult to get at and are going to require our imagination and our activities. And I would point to what David Seltz pointed out. We've tried to deal with many of them in our recommendations, and we hope that in the coming days, weeks, and months, we can work with your staff to see to what extent the state needs to be doing more. So with that said, unless somebody wants to jump in, I really want to thank all of the presenters. We're now going to turn the program over to presentations by the public. And I'm going to ask our really wonderful Deputy Executive Director, Colleen Alstemeyer, to lead us in this public testimony. Colleen?
I am so happy to do that, Mr. Chairman. I just saw Professor Cutler raise his hand if I could give him a minute.
We always give Professor Cutler a minute.
That's your first mistake.
Maybe so, but I'm deferential.
I just want to sort of raise one issue and ask one question of Dr. Sen, which is, the counterpart to high and rising prices, say for hospitals, is that hospital margins are essentially zero. There may be 2%, maybe 4%, and so on. So the prices keep going up, but the money keeps getting spent. And so one view is, well, maybe they're just spending it in terrible ways, and it'd be better for people not to have that. But there are two other possibilities that I think would be important, and I'm wondering if you have any sense about how big they are. One is rising administrative costs, which would show up as higher prices here because all the administrative workers in the hospital will show up in the prices. And to the extent that that's there, we need to try and address the underlying administrative costs while we think about the prices. And then the second one, and particularly this might be an issue very recently, is rising labor costs. So nurses who are demanding higher pay because that's what people are getting, travel nurses, people who are out because of COVID, but you still need to staff things. So your staffing has gone up. So that obviously wouldn't be a long-term thing, but that might be a short-term thing. So I guess I'm wondering what I should make of whether the real issue is it may be more something on the admin side than on the price limitation side, or maybe I need to think about both, or maybe I shouldn't think about it. And there's a lot of money which is just being wasted. I guess I just want to toss that to you.
Yeah, no, thank you. That's a great point. And I am very familiar with your work on administrative spending as well. And I know that, a lot of the kind of big picture health expenditure data, like, the NHE and others, and even in claims data, right, as you're saying, like all of the administrative spending kind of gets baked in to the final price. And it's hard to pull out upcoding. It's hard to pull out the administrative side. So I completely agree with that. And I think, there is plenty of good data, including yours, that our administrative costs are much higher than in other countries. And they're even, much higher in the private insurance than they are in a program like Medicare. So I think that there is certainly a lot of room to address those administrative costs as well. I guess what I would say is, I think that if, as people in this Zoom room know better than I do, if this were sort of simple, we would have done it already. And so I think, there doesn't seem to be a silver bullet for this, right? I think like reducing, capping prices in certain situations, looking at sort of things on a hospital, or at least by hospital kind of category, which hospitals have really high administrative costs. And the problem is that in a lot of cases, we don't have great data on some of those pieces. But I completely agree with you that I think, understanding more and thinking more about the rising administrative costs and how to handle that. And I think sort of having an idea about where hospitals could start to reduce prices would be really important. And, sort of more understanding, I know MedPAC has done some work on the sort of efficient hospitals, but I think that is an important area for researchers, policymakers to understand more about, is sort of where in the hospital, billing and admin, provision of low value care, where can we start addressing this high spending? How much is price? How much is sort of changing some of these practices like low value care and high administrative costs?
Well, forgive me, David Cutler, but there's a third component, which is not trivial and maybe the most important, which is how much the hospitals have to spend for the technology and the drugs and the related stuff that they use to provide that care. And we do know that the technology and the drug prices are going up. Much of our drug spending is outpatient drugs. Mm-hmm. We don't see a lot of the costs implications of the very expensive cancer drugs and others that are baked into the hospital rates. So, David, I would add a third component.
Yeah. I agree. I agree. And that suggests that we need to be looking at some of these underlying issues.
Absolutely agree. Don't disagree at all. Chris, you wanted to say something?
A quick one for Dr. Sen. On physician spending on injectables, can you break that down by employed physicians and employed by hospitals versus other and independent physicians? Is that possible?
Yeah, so that's a great point. And I think we don't kind of have that written into our data because it's not really a part of claims data. But I think now there are beginning to be more reliable sources for knowing that kind of thing about physicians, which physicians are linked to which systems, which we can link to our data.
That may be a question then for CHIA, because we have
Massachusetts, of course, has a lot of
we
that
have
data.
that data by site of service, and that, I think it'd be very helpful to
Very
fill in.
helpful.
And last, could you send us the Brown and Eisenberg papers? Send it to the commission, to the HPC, so we can take a look at those papers.
Yeah, for sure.
I think they were
That's wonderful.
both 2021 papers. That'd be great.
Yeah, I'll be happy to.
Great. Let me now turn it over to Colleen to introduce the public testimony.
Absolutely. Thank you again to Dr. Sen. Moving to the public testimony portion of the hearing. So advanced sign up was required for live testimony due to the remote nature of the hearing, and we have 9 people signed up to testify before the commission and the joint committee today. Oral testimony will be limited to 3 to 5 minutes per speaker, and I will let you know when you have 1 minute left and when you're out of time. Members of the public are also invited to submit written testimony, which will be posted to the HBC's website. The deadline for submitting written testimony is this Friday, March 18th at 5 p.m. Any more information that you're looking for is on the HBC's website. After folks testify, if there are questions from HBC commissioners or members of the Healthcare Financing Committee, for any testifier, please just raise your hand or chat to me or Chair Altman, and we'll call on you. With that, we are going to start with Deb Wilson, who's the head of Lawrence General Hospital, and on deck will be Liz Leahy from the Massachusetts Association of Health Plans. Deb?
Good afternoon, Chairman Altman, Senate Chair Friedman, and House Chairman Lawn, members of the legislature, Executive Director David Seltz, and other distinguished members of the committee. My name is Deb Wilson, and I serve as the President and Chief Executive Officer of Lawrence General Hospital. Lawrence General is a 186-bed hospital located in the city of Lawrence, and we currently provide the full array of community inpatient and outpatient services, including trauma, maternity, pediatrics, special care nursery, cardiac, surgical, and emergency care. And we provide over 65,000 emergency visits a year. While your focus today is on understanding where prices and spending are growing, I want to share with you where they need to grow, but they have not been growing at hospitals like Lawrence General. For every year that CHIA has published price data, Lawrence General has been among the lowest paid. Our rates from commercial insurers are 25 to 30% lower than the average hospital's rates. And Medicaid rates, which we depend on, do not even cover the cost of care. And this leaves us barely sustainable. Lawrence General is located in the largest community of color in Massachusetts. 80% of the city are residents of color. And we have had the single highest rate of COVID in the Commonwealth, 42,000 per 100,000 residents. If ever there was a question about whether a hospital is needed in Lawrence, the pandemic answered it. We cannot talk about health equity when a hospital like Lawrence General is paid barely enough to sustain our services. Disparities in rates contribute to health inequity. And to sustain services in cities like Lawrence, we require improved rates, improved payments, not grants, not incentive payments, and not short-term initiatives. We require structural improvements in our rates for everyday healthcare services that save lives. While your focus today is on growth in costs, some providers have been starved for resources, and those providers are in cities like Lawrence that serve the most vulnerable, and that's not acceptable. I am very hopeful that the stark difference in COVID rates and the crucial role that hospitals in low-income urban cities play and their threatened financial viability will inspire some to say it is time to address and lift the safety net hospitals before we lose them. We are becoming an endangered species and threatened. We were challenged by having among the lowest commercial rates before COVID, and Medicaid rates were cut. And now the pandemic has taken a tremendous bite out of our modest financial reserves. We require legislation, policy intervention, and structural fixes to inadequate growth in rates to survive for the long term. And it is not enough to focus on where cost growth is beyond ideal. You must also focus on where nominal cost growth is unsupported. And there is no health equity without a structural remedy to our long-term structural underfunding. And thank you for your time today.
Thank you so much, Deb. Do we have any questions for Deb before we move on to Liz? Okay, seeing none. Liz Leahy.
Thank you, Colleen. Good afternoon. Thank you, Director Seltz, Chair Altman, and Commissioners, Chair Friedman, Chair Lawn, and members of the Healthcare Financing Committee. I'm Liz Leahy, Vice President of Advocacy and Engagement at the Massachusetts Association of Health Plans. We represent 16 health plans and 2 behavioral health organizations that provide coverage to nearly 3 million Massachusetts residents in the commercial market on the state's Health Connector, with our provider partners in the Mass Health ACO program, and for duly eligible individuals in both Medicare and Medicaid. We appreciate the opportunity to again provide our comments on modification of the state's healthcare cost growth benchmark. In years past, we've offered our support for a strong benchmark and have highlighted persistent underlying drivers of healthcare costs in our state. And this year, while our comments remain largely the same, it certainly feels like we've reached an inflection point for cost containment in the state. As Director Seltz said at the outset, it has been 10 years since the passage of Chapter 224, the landmark legislation that created both the Health Policy Commission and our first in the nation healthcare cost growth benchmark. In that time, the data and analyses put forth by the HPC, the Center for Health Information and Analysis, and the Massachusetts Office of the Attorney General have confirmed time and again that the very same factors continue to challenge our collective ability to meet the benchmark. The first, persistent increases in the prices that doctors, hospitals, and other providers charge. The second, care shifting and largely being delivered by high-cost providers and high-cost settings. And the third, continued excessive spending growth for prescription drugs. Health insurance premiums are a direct reflection of the cost of healthcare. When drug makers, hospitals, and providers increase their prices, employers and consumers bear those costs in their premiums and cost sharing. In Massachusetts, health plans are heavily regulated, with strict requirements at the state and federal level for premium dollar spending. If, as was the case in 2020, utilization of healthcare services is below actuarial predictions, health plans must issue premium rebates to employers and consumers. In 2021, health plans issued close to $60 million in rebates. We will continue to see the impact of COVID-19 on MLR rebates over the next couple of years, but I'd be remiss if I didn't also highlight the rebounding in utilization in 2021 as care returned to in-person settings, as well as the impact of waivers for member cost sharing, cash assistance issued to providers, significant expansions in telehealth access, and premium payment grace periods on health plan use of the premium dollar from mid-2020 to today. In addition, health plan surplus is monitored closely by the Division of Insurance, with a 1.9% cap that may trigger disapproval of premium rates and ongoing monitoring of health plan reserves to ensure health plans have sufficient capital to pay unanticipated claims. There is no corresponding regulatory framework for drug makers, providers, or hospitals, but we do have the benchmark. The cost growth benchmark and the corresponding performance improvement plan process are vital tools to constrain costs, but the commitment of all healthcare entities to the benchmark has begun to fray in recent years. Health plans are reporting requests for double-digit rate increases from hospitals and providers, citing increases in labor costs from staffing shortages, while drug makers continue year-over-year increases in prescription drug prices. As CHIA found in their annual report, from 2020 to 2021, even when taking into account rebates, prescription drug spending grew by 7.7%, well in excess of the 3.1% benchmark. Without accountability to the benchmark, we are fearful that health plans will lose a valuable negotiating tool, and there will be limited opportunity to bend the cost curve in the future. Now more than ever, action must be taken to curtail continued increases in both unit price and total medical expenditures. In conjunction with a strong benchmark, we urge the state to take steps to hold all entities accountable for cost growth, enhancing competition, and correcting market dysfunction. For drug makers, this means joining with payers and providers in participating at the HPC's annual cost trends hearing and providing data to HPC, CHIA, and the Attorney General as envisioned in the Senate's recent PACT Act and the governor's healthcare bill released yesterday. We also support expansion of the HPC's drug pricing review authority to include drugs with a financial impact on the commercial market. And we caution policymakers against efforts to eliminate important health plan tools like use of specialty and mail order pharmacy networks. For hospitals and providers, this means ensuring full system accountability to the PIP process, not just for primary care provider groups. We recommend more detailed reporting and analysis on total medical expenditures and TME trend at the hospital rather than the system level, as well as a much needed analysis of labor costs for hospitals and providers in Massachusetts in comparison to similar markets. MAP and our member plans are committed to ensuring access to high quality, affordable, and equitable healthcare services. The healthcare cost growth benchmark is an important tool to meet these goals. Without a strong benchmark, we lose the needed shared responsibility necessary to hold all entities accountable for healthcare costs in the Commonwealth. Thank you.
Thank you so much, Liz. We actually have a question for Deb Wilson, our first testifier from Dr. Berwick. If Deb could come back in for a minute, please.
I'm here.
Hi, Deb. Thank you, and thank you, Liz. Deb, I just have a question for you. If this puts you on the spot too much, don't answer. Just you get back to it later. But so you're asking for more support, but I don't think you would want a blank check, or I mean, that's not going to happen. Have you done any modeling? How much of an increase would lead you to say, "Thank you, we're done. That's what we need"? That is. You ever model that, or were you willing to give us some peek at that, or could you at some point?
Yes, absolutely. We have modeled that. So we've modeled two things. One, just going back to our 2018 mass health rates and applying an inflation factor, what that would do for us would be incredibly helpful and ensure our stability and sustainability. So we are not, the Medicaid cuts were dramatic back in 2019. And for an organization like ours that does a high level of imaging related to the emergency center services, those cuts were dramatic. And I know you've heard about them before and the impact. But if we were to go back to 2018 mass health rates with an inflation factor, that would be incredibly supportive to our organization and allow us to sustain services. And then, of course, on the commercial side, we would like to be paid at, at a minimum 90% of the average commercial price across the state, because we're experiencing the same workforce challenges, inflation that every other organization is experiencing, but our commercial rates have not been legislated to be at an average rate. So again, there is a path forward and we are sustainable, and we absolutely don't need or want a blank check, but it is incredibly challenging to have really taken on extraordinary cuts while all of the costs around us have gone up.
Thank you very much. I appreciate that.
Thank you, Deb. Thank you, Liz. We have had a couple of no-shows here, so we're going to move right on to Chris Carlozzi from the National Federation of Independent Business, and then on deck is Steve Walsh from MHA. Chris, are you ready for us? Thank you.
Thank you, Colleen. I appreciate it. And I apologize, I'm not on video. I'm on the road today, so I am traveling and in a car, but my name is Christopher Carlozzi. I am the Massachusetts Director for the National Federation of Independent Business here in Massachusetts. We are a nonprofit, nonpartisan organization, and we are the nation and our state's largest small business advocacy group. And we represent a wide range of industries, including manufacturing, retail, wholesale, service, hospitality, agriculture. The average one of our members has about 5 employees, and we represent that small Main Street business from across the state. Small businesses are still in a prolonged recovery. In NFIB Research Foundation's most recent Small Business Optimism Index, 26% of business owners' top concern right now is inflation. 48% of employers cannot fill open positions. 45% have reported raising compensation. 68% have raised prices on consumers. In short, small businesses still face a myriad of challenges. They are paying more for products, coping with labor shortages, dealing with rising fuel costs, responsible for paying down billions of dollars in unemployment insurance debt, and on top of it all, still face some of the highest health insurance costs in the nation. Despite the current economic conditions, small business owners in Massachusetts still list the cost of health insurance as a top concern, as they have for well over a decade now. Offering insurance to workers in the Commonwealth is a significant cost of doing business and has an impact on overall job creation in the state. For 2019, overall health spending exceeded the growth benchmark for a myriad of reasons. In past years, Massachusetts growth was reported below the national spending average and considered in a more advantageous position until growth exceeded that 4.3%. But what concerns small employers, if they never experienced any cost savings when trending in the right direction, what will health expenses look like when Massachusetts is heading down the wrong path, especially factoring in pandemic-related costs? As the Health Policy Commission recognized in a previous cost trends report, at one point, Massachusetts small businesses and their workers experienced the second highest health expenses in the nation. Small businesses are still feeling those cost pressures, only with the additional financial strain of operating during an economic crisis, as well as the aftermath of a pandemic. Small business owners cannot really understand why they face continual health cost increases, especially seeing individuals and government workers often experiencing cost savings. Affordability is still a major issue for small businesses and something lawmakers need to address to ensure greater equity for small businesses in the health marketplace. Some would argue that Massachusetts' unique merged market is resulting in an unfair cross-subsidy scenario, with small businesses paying higher premiums while individuals in many cases pay less. When the 2006 health reform law was passed, merging the individual and small group markets, a series of rating factors were included to prevent premium spikes for small businesses. However, at this point, all of the rating factors that once protected those small businesses were phased out. Yesterday, Governor Baker released a bill, and in it includes some reforms within the merged market. So we're hoping that provides some relief to employers, but only time will tell. As small businesses face labor shortages and struggle to attract new workers, the ability to offer affordable health coverage is more important than ever. Small business owners grow weary of hearing that Massachusetts leads in health reform when every year they experience increased costs. Employers can no longer endure these annual premium increases that make small business growth and job creation extraordinarily difficult. We have a survey out to our members now in the field, and we're hoping to gather some data over the next couple days to see what their premium situation looks like at this point. Because we feel that legislative solutions to make health insurance more affordable for small businesses and their workers are often hard to do, and meaningful reforms never seem to usually make it. We still worry very much about mandated benefits and the cost of that, and added benefits over year that seem to be tacked on every legislative session. And that's something that a lot of small businesses are concerned about and leading to some cost growth for them. But for all these reasons, the benchmark should remain an aggressive benchmark, and Main Street businesses across Massachusetts and their workers cannot endure ever increasing health premiums. The state must begin to finally address the cost of insurance and the barriers to affordability for small employers within the merged market. Thank you.
Thank you very much, Chris. Okay, we have Steve Walsh from the Massachusetts Hospital Association, and then on deck is Alex Sheff from Healthcare for All. Steve, take it away.
Thank you, Colleen. Good afternoon. I'm Steve Walsh, President and CEO of the Massachusetts Health and Hospital Association. Chair Friedman, Chair Lawn, Chair Altman, Executive Director Seltz, Executive Director Campbell, HPC commissioners and members of the Joint Committee on Healthcare Finance. Thank you for the opportunity to testify today. You received detailed written testimony with more information than I can offer on some of the things I talk about and some that I do not. I come before you at a time when our healthcare system remains incredibly fragile. The discussion today, as interesting as it is from 2 years ago. Our health system is not the one that was described in the presentations today. Frankly, I wish it was. We are finally emerging from 2 tumultuous years, which have affected our healthcare organization's ability to provide care, to remain economically stable, and to meet the needs of our communities and our patients. Our challenges have never been greater, and the uncertainty and the volatility has simply not gone away. I always appreciate the discussion, and I appreciate that the charge of this commission is to go through this exercise. But I do want to caution the commission about relying too much on where people chose to get their care. People really didn't choose where to get care in 2020. Field hospitals, community health centers, community hospitals, shelters, surge spaces, tents, wherever patients could get care. It was the worst experience of every caregiver's career. And frankly, COVID was not a negotiating tactic. I want to talk about that time in 2020 a little bit, because it's still important to mention the special appreciation for those that enabled our healthcare organizations and their caregivers to survive. Secretary Sutters has been our North Star, partnered with us in every way to make sure our Commonwealth fared as well as it did. Chair Lawn, Chair Friedman, your partnership and support is unwavering through every twist and turn. Governor Baker, Speaker Mariano, President Spilka helped ensure that our healthcare community had the resources, flexibilities, and protection that it needed to meet the demands of our patients. And Executive Director Seltz and Deputy Director Elstermeyer, your work and the work of your team at the HPC has been nothing short of extraordinary. You have been a partner and a collaborator in every way. The spirit of the entire system coming together with a common purpose is the only thing that got us through the darkest days. And it's in that spirit that I join you here today to talk about the cost growth benchmark. It often seems uncomfortable to talk about funding and money in times such as these, but that's your charge and our collective responsibility to keep our system functioning and hopefully once again thriving. But it is hard to believe that we're approaching nearly a decade since the landmark Chapter 224 law was passed in 2012. After 10 years, it's understandable there are only a few people left who understand the legislative intent and the goals surrounding that law. While it is statutorily required for the commission to revisit the benchmark, more importantly, it's also a critical time for a retrospective on the law, the areas in which the law succeeded, the areas of progress, and the areas that now require some needed evolution. And the necessity for this conversation is right now, because at the 10-year mark, that's the moment where the legislature cedes control of the benchmark directly to the hands of the commission. And that's why I'm hoping we can have a productive dialogue about this today and in months ahead. Now, I may be here as a representative for the Commonwealth's hospitals and health systems, but as someone who is deeply committed to Chapter 224. As you know, this law is a labor of love and a pride for me personally. Every day when I enter my office, I see the pen that Governor Patrick used to fix the last final point of his signature on this law on August 6, 2012. So I'm also able to look at it through a different lens. I believe in its promise, I believe in its goals, and I am certainly self-aware enough to understand its shortcomings. It's important to also remember, as Commissioner Cutler does, that the powers were balanced very carefully with the makeup of the commission. It's an all-volunteer board, a board that does not allow any representatives from any of the industries that it serves to protect against the appearance of any conflict. Its focus was always on the policy levers that could move a sector to be better, to do better, and to safeguard consumers when it comes to the cost of their care. It's because of this that the benchmark was initially set at 3.6%, 2012, then automatically dropped to 3.1% after the 5-year mark, unless the legislature proactively made a change, as Director Seltz talked about earlier. Now the benchmark's in your hands under the original provisions of the law. So in 2012, we had hoped that the benchmark, coupled with a push towards accountable care organizations and other innovative payment models, would move the market more quickly to value, resulting in significant reductions in cost of care. Now, we continue to hope that that transition to value-based care accelerates, and we are beginning to see some progress to paying for quality instead of quality, but it has taken more time than I think all of us would have hoped. I know this is welcome news for the commission that there is some progress, and of course for our legislators and for our patients. But when we made the historic move to set a benchmark, it was carefully based on the assumption of smooth growth, moderate inflation, and typical economics. Of course, the current financial realities facing our healthcare providers and our Commonwealth as a whole are anything but smooth. Again, to rewind to 2012, the idea for the benchmark is that it would be set at roughly 1.5 points greater than inflation, which had averaged at 10% smoothed over 10-year trends. Of course, this standard would be incredibly unrealistic at this time. because inflation at the moment is at 7%, which means the benchmark would need to be set at 8.5% or higher simply to be consistent with the way the metric was created and envisioned. So this leads us to one of the inherent flaws of 224. By its very nature, it has you assess the past in order to regulate the future, while all the while never focusing on the present. And this is the key point we face today. You are statutorily barred from accounting for real-time factors affecting the healthcare ecosystem. In normal times, this may not pose a challenge, but the past 2 years have shown that conditions can change on a dime. And what is happening at this moment must be considered in a comprehensive analysis of how the system is performing. When we look at the economic pressures brought on by the pandemic, they are simply too extreme to ignore. For the sake of our healthcare system, the needs of our workers, and the care of our patients, we need to be living in the present. It's time to utilize the wisdom of the legislature to modernize our approach to the cost growth benchmark. I know the commission has historically wanted to ask our elected leaders for various changes to the 2012 law. So let's do it now. Let's request that the legislature give this due diligence and attention that it requires and deserves. Let's evolve the tool to better meet the demands of the times. I know members of the legislature will have the best interests of their constituents top of mind as they contemplate and debate the new realities that are facing their communities. Simply look to 2020. Total statewide healthcare expenditures declined by 2.4%. Operating margins were not completely decimated only because of the $1 billion in one-time state and federal relief. So it could have been much worse. At the same time, insurance costs increased by 8%, despite utilization decrease of 5.3%. Now, that isn't to suggest fault on any side. It's simply to state the facts that illustrate how the current law isn't working relative to growth in real time. We all want lower healthcare costs. We all want better access and the highest quality services for our patients. The choice you have in front of you today just makes that impossible. You can't do it even if you wanted to. Even the best, most groundbreaking systems, like the ones we have in place in Massachusetts, need to be revisited based on a changing of the times. We should request a slight pause in the establishment of the new benchmark to ask for assistance from the legislature so 224 can be fortified with the realities of 2022 and beyond. The system bears examination in several key areas. First, if the commission wants to continue to ask for an increase in its power and authority, and maybe you feel you need to better regulate the market, the composition of the board needs to be reassessed. As I mentioned earlier, the powers of Chapter 224 were very carefully contemplated based on the makeup of the board. The legislature should consider following the model they appropriately chose for the Gaming Commission and the Cannabis Control Commission and professionalize the board of the HPC. It's not to suggest that this board is incompetent, talented, and doesn't put the time in. And frankly, I hope some of the members would be reappointed as full-time commissioners. But the dynamic and evolutionary state of healthcare in Massachusetts deserves and demands full-time paid commissioners who can focus solely on the healthcare ecosystem in our Commonwealth. Second, the legislature should look at the benchmark within the context of factors like inflation and the rising cost of labor. It should decide what's appropriate when you take into account all the present-day challenges our healthcare community faces. Labor costs on their own are rising to unsustainable levels. Labor spending usually accounts for 69 to 71% of total expenses. Today, that number is approaching 80%. And in some areas for any given provider, it's even higher. Now, this has made it incredibly difficult. And I know the commission discussed the rising costs in other industries at their last meeting, but healthcare is unlike other sectors. Costs are not changed unilaterally. They're done by contract with multiple payers, both public and private, with input costs increasing so dramatically and rapidly, it's the perfect time for our legislative partners to dive back in and reassess the levers of the law. Third, the legislature should ask for the commission to focus on the healthcare workforce. Our professionals are the people who show up every day to care for our loved ones in jobs that are harder than they've ever been. They'll do it today, they'll come back tomorrow, and the next day, and the next day. But they're exhausted, they're burned out, and they're suffering with their own mental health challenges. They've seen unspeakable things over the past 2 years. MHA and our members are spending each and every day addressing the mounting challenges with the workforce, so these professionals feel safe and supported. But I hope the legislature in its wisdom will ask you to look into programs like free community college, loan forgiveness, an AmeriCorps type training program, and guaranteed placement afterwards. We need to attract, educate, and retain more people for the incredible vocation of being a healthcare worker, and the HPC is the visionary agency that can make this dream a reality. Chair Law and Chair Freeman, I know firsthand how you have visited hospitals and post-acute facilities. You've talked to frontline workers, you've met with patients. I know many of your colleagues in the legislature have done the same. The governor, the secretary, the attorney general have spent countless hours in the hallways and offices of our hospitals. I know it may be a lot to ask for you to do a little more, but if we are ultimately going to fulfill the promise of those of us who undertook this journey together in 2012, including Commissioner Cutler, Commissioner Altman, Secretary Sutters, Director Selt, and Deputy Director Elstmeyer, we need your help. Please take an interest in evolving this landmark legislation today to make sure the next 10 years are even better than the first. We need to ensure that we're giving the Health Policy Commission the appropriate tools, resources, and oversight to undertake its mission on behalf of our healthcare providers, and most importantly, their patients. I would also invite any commissioners to join me in visiting some of our hospitals. See our healthcare providers up close. Talk to some of the frontline workers and support staff. Walk the halls of the hospital. Understand what's at stake in today's environment. This isn't an academic exercise. It's an unprecedented challenge that our providers are facing. It's about people. It's about patients. Our patients and our consumers need this commission, as incredibly talented and well-meaning as you are, to not be living in the past or planning for the future. They need all of us to be in the present, standing right alongside them. Chair Law and Chair Friedman, we'll need your assistance to make it happen, but I know you and your colleagues are up to the task. Thank you for allowing me to join you today and for your ongoing support of our healthcare system, and I'm happy to answer any questions.
All right, thank you so much, Steve Walsh. Do we have any questions for Steve Walsh? If not, we have Alex Sheff next up, and on deck, last but not least, is John Hurst from the Retailers Association of Massachusetts. Alex, great, thank you.
Hi there. Thank you. So my name is Alex Sheff. I'm co-director of policy and government relations at Healthcare for All. We operate a helpline that takes 20,000 calls a year, and we advocate for health justice in Massachusetts by working to promote health equity and ensure coverage and access for all. So thank you for the opportunity to testify today. The HPC benchmark is a critical tool to monitor healthcare costs and hold our system accountable for keeping them under control, so individuals and families aren't forced to choose between getting care and putting food on the table. CHIA's 2020 annual report reflects a highly unusual year, as many have noted, as the Commonwealth grappled with the first waves of the COVID-19 pandemic. The state should not make long-term policy decisions based just on the trends reflected in this report. However, it does include several clear points that remain troubling for consumers, especially the continued rise in prescription drug costs. While the report shows consumers paid less than out-of-pocket costs as a result of the temporary drop in spending in 2020, the continuing trend towards high-deductible health plans relative to other plan types is an ominous sign that people's costs will increase as healthcare use returns to normal. We also are concerned about how much money insurers kept from their financial gains due to the unexpected drop in healthcare services and use of healthcare services. The funds insurance kept, as was noted, jumped more than 35% even after accounting for rebates and credits paid back to consumers. Yet, premiums rose significantly in 2021 and 2022, and family premiums nearly tripled over the last 2 decades. In addition, a survey conducted by the Altarum Institute last year found that more than half of Massachusetts residents reported having an affordability burden, such as foregoing care due to cost, and 75% were worried about affording care in the future. There were also stark racial disparities, with Black and Hispanic residents being significantly more likely to report challenges affording care. But data is only part of the story. We hear daily from callers on our helpline about the challenges they face. One caller, Verzina from Mattapan, has 2 jobs. One is a teacher, but neither offer health insurance, so she has to buy coverage on her own. Her plan costs $467 a month and has a $2,700 deductible. Recently, her primary care doctor discovered a lump in her chest and sent her to get a mammogram, for which she was billed $1,000. She's paying it off in installments, but she says she won't go to any other appointments because, as scared as she is of the lump, she's more afraid of what another visit will cost her. Experiences like Verzina's are why Massachusetts must remain focused on the question of how to blunt the rise in healthcare costs paid by consumers. Recognizing that the costs paid by individuals and families have continued to grow at unaffordable rates in many years under the benchmarks as they have been set so far, we actually think a lower benchmark may need to be considered. So that's why we recommend that the benchmark be set no higher than 3.1% in 2023 and potentially below 3.1%, though we defer to experts with access to more data to determine the specific correct level. However, more action is needed to protect people from healthcare costs that cause financial harm and create barriers to care. There are 3 important updates to the HBC benchmark process that Healthcare for All thinks should be considered. First, we recommend setting a separate consumer benchmark as part of the HPC's benchmark process. The goal would be to track the costs individuals and families pay for healthcare through copays, deductibles, and premiums, and hold the health system accountable for ensuring they don't grow faster than the overall benchmark. Not only would this shine a light on those costs and build them into the benchmark process, it would also begin to tie consumer costs to overall system costs and ensure consumers aren't responsible for more than their fair share. Second, we think it's important to measure and have accountability for hospital costs beyond just the primary care patients attributed to health systems, given how much of a driver inpatient and outpatient hospital costs have been in the years prior to 2020. Third, it remains long past time to bring prescription drug manufacturers into the HPC review process that applies to other industry stakeholders, including providers and insurers, as a proposal pending before the legislature would do. Medication use, as we saw, did not decrease in the same manner as other healthcare services in 2020, and instead prescription drug spending grew nearly 8%, more than twice the benchmark, even net of drug rebates. It's also worth noting that we are closely monitoring the current PIP process with Mass General Brigham to see if it will result in meaningfully lower costs for individuals and families. If it doesn't, we will need to look towards stronger accountability mechanisms as part of the PIP process to change the incentives for our healthcare systems to lower costs and make care more affordable and accessible to all residents. Thank you again for the opportunity to testify today.
Thank you so much, Alex. Okay, if we have no questions for Alex, I am going to move to our last testifier, John Hurst from the Retailers Association. John.
Thank you, Colleen.
Welcome.
Okay, get my video on. There we go, I believe. Good afternoon, everyone. Thank you, Colleen and David, and to the co-chairs, as well as to the entire commission. Thank you for your time this afternoon. Thank you for allowing me to come to what is now an annual tradition coming before the HPC on the benchmark hearing. I'll cut to the chase. The Retailers Association of Massachusetts with 4,000 members, we firmly believe we need to retain the 3.1% benchmark, and we urge the commission to do that. And let me, if you could indulge me, if I could share the screen, I believe I can do it. This is, those of you that have been on the commission for a while know that we survey our members every year on the health insurance premiums. We've been doing it since after the passage of Chapter 58. The blue line here is the increases in premiums reported by our members. The red, just for comparison, is the GIC, as was pointed out earlier in the hearing, which of course is the state, which is self-insured. A lot more ability and different market forces and ability to not have to cross-subsidize others that the GIC does enjoy. And then of course we have the inflation rate down the bottom, and then we have in the green the benchmark for the last decade. For this year, our increases reported was 10.96%. Now it's important to note that actually our members do not end up paying that much. Okay, that's what they're being asked to renew their membership, renew their premiums of their health insurer. This year was 10.9%. Of course, what they do each and every year is they have to look at ways to save money for themselves and their employees, for small businesses. The top movement this year of our members was to increase deductibles, increase cost sharing. Number two was to move to another insurer. In fact, those two options made up about half of our membership. 25% increased deductibles, 25% moved to a different insurer. Interestingly enough, only about 10% actually increased the premium co-share share to their employees, and that which I believe, in past years there might have been more movement in that direction, but this year, with what's going on in the labor market, and attracting and retaining a labor force, you can't afford to raise the premiums of your employees if you're a small business and keep them, in your workforce. I would point out, back on that chart, you might have noticed in the year 2010, that was a pretty blunt year where we had double-digit increases. For our members, it was 22%. Even the GIC was a very high number. That was the year in which the DOI actually disallowed the increases by the health insurers, you may recall. And that created a real a sledgehammer, so to speak, for the insurers to go back and beat up the providers and renegotiate those contracts. And the following years, along with the passage of 224 and the creation of the benchmark, created some stability in those following years. We don't have that stability. We're concerned about the future. I am, however, encouraged by the legislation filed this week by the governor, which creates a little more advantages by the DOI, more regulation, but also creates some market forces for these small businesses, which was earlier mentioned. We are in that merge marketplace. This is the first year since the passage of the ACA in which there are no rating factors. We had that deal with the federal government for many years for small businesses to have rating factors because we were the only state in the nation to have a merge marketplace in order to come up with fair rates for small businesses. The Biden administration took those away from us this past year. So this is the first year, no rating factors. That's a real concern for small businesses. So the governor did put some other market forces into that bill that we would look forward to working with Senator Friedman and Representative Lawn on that legislation. And finally, let me just say, on December 31st, the U.S. Census came out with the updated census numbers for across the country. Massachusetts was ranked 4th in the nation in population loss. We were behind New York, California, and Illinois. We had a net loss of population. That fact, which of course is less people that we're covering, but also a real negative economic figure for people that might want to stay here and invest here, is something we got to keep a close eye on. We've got to keep track of the healthcare costs and contain them. And we also have to take a look at the fact that these small businesses also, like the hospitals, went through a tough time over the last 2 years. A lot of money rightfully went to our providers, a lot of COVID money, tens of billions of dollars. We have to keep track of those dollars, and we have to understand that those dollars were there, and also keep those factors in play as we move forward, that perhaps, with the lower utilization numbers out there, yet higher costs that still went into the system, both through premiums, through tax dollars, federal tax dollars, perhaps now is not the time to lower, or to raise rather, that benchmark figure. Thank you for your time and your consideration.
Thank you, John. And with that concludes our public testimony. Back to you, Mr. Chair.
Thank you, Colleen, and thanks for the presentations. Well, they presented a lot for us to deal with. So I'm very conscious of the time, and that we're hitting the 3 o'clock time limit. I just want to thank everyone for coming. We will be having a full commission meeting on the 13th of April. And we will go back over much of this material. I want to thank David Seltz and the staff for putting together a phenomenal set of presentations. A lot to think about. So unless there's a burning comment or question, I particularly want to turn it back to our legislative people if they have any final comments or questions.
Thank you, Mr. Chair. I think as you said, it's been incredibly informative. Lots and lots of stuff to digest. lots of different priorities, but some very low hanging fruit. And so I hope that I can work with my becoming good friend and colleague, Rep. Lawn, for us to get that priority list, put the low hanging fruit up to the really, really tall trees and get some of this done so that we can address this really, really serious problem that's facing our residents. And that's making healthcare unaffordable and inaccessible. So thank you. And thank you so much. It's a real honor to be part of this discussion.
Oh, thank you so much.
Thank you, Dr. Altman. I just wanted to say thank you to everyone and to Dr. Sen for her presentation. There was so much information, and I think as some of the presenters had mentioned, we do have some challenges in real time. During that last surge and visiting so many of our hospitals and seeing firsthand the challenges from mental health to ER boarding, to really the staffing issues. And as much as the costs that we talked about today that are we talked about from 2 years ago, and information that we're looking at, to really see the workforce challenges that we have and what we're going to do about them is really going to be a cost, because we need people to be able to take care of people. And all this other stuff is all important, but we really have got to focus on, as Senator Friedman said, some of these low-hanging fruit that we can't even get to unless we get people to take care of people and support our hospital systems throughout the state. And being able to see the different challenges that each hospital system has, each geographic area has, was really eye-opening for me as I traveled throughout the state to many different hospitals. So I look forward to working with Senator Friedman, and I know all of you. Some very important issues were raised today, and I think we all have to weigh in on and work together collaboratively. But I'm very cognizant that we will do that and be able to. So thank you again, and Dr. Zen, thank you very much for your presentation.
Okay, David Seltz, do you want to say any final words? You're good? All right, so I will accept a motion to adjourn. I hear it's unanimous. Okay, well, thanks everyone, and we will see you on